Spoštovani gostje, dobrodošli ob začetku dvodnevne mednarodne konference na visoki ravni o uporabi inovativnih rešitev za odporne zdravstvene sisteme, ki bo v naslednjih 2 dneh potekala v Ljubljani in po spletu. Organizator je Ministrstvo za zdravje Vlade Republike Slovenije, dogodek pa je del aktivnosti v okviru predsedovanja Slovenije Svetu Evropske unije. Delovni jezik konference bo angleščina, zato vas prosimo za razumevanje. Ladies and gentlemen, dear guests, you have just heard an introduction to the event in Slovenian, the language we are so proud of. It's very old, it's complex, but it's also innovative and resilient. We're now switching to English, which will be the working language throughout the conference. This is a high-level conference of the Slovenian Presidency of the Council of the EU, organized by the Ministry of Health of the Republic of Slovenia. We will discuss the implementations of innovative solutions for resilient health systems. This is a so-called hybrid event. We are hosted in a studio in Ljubljana Castle, above the Slovenian capital. Some of the participants, speakers, expert moderators are actually here. Some of the participants, of course, will join us online. The whole conference will be webcast. Some of the panels will be also interactive. The Ljubljana Castle is a very picturesque, beautiful host for the conference. It is also a very safe venue with high security standards regarding measures against COVID-19. All attendees are either vaccinated or tested. And I'm very pleased to announce the opening speaker and host of the conference, the Minister of Health of the Republic of Slovenia, Mr. Janez Poklukar.
Dear Commissioner Stella Kyriakides, fellow ministers, honored guests, ladies and gentlemen, a very welcome to all of you who will follow this high-level presidency conference on implementing innovative solutions for resilient health systems. I'm very happy that some of you have made it to Ljubljana and will be able to join me in discussion in person. Especially, I would like to welcome Dr. Hans Kluge, Regional Director of the WHO. I invited him to have a keynote speech to set the scene for our discussions. I would also like to thank the team from the European Observatory on Health Systems and Policies. They supported us all the way along in preparing this conference and the policy brief that serves as a background document for the conference. For those of you who could not be here in person and will follow the conference online, we prepared some virtual experiences leading you through natural beauties and culinary delights of Slovenia. Our health systems that will be in the focus for the next 2 days are an important strength of the EU. They are diverse, but they provide good health care to our populations, contribute to longevity and well-being, and in general to development of our societies. All our health systems have a long tradition and share some common core values. Let me name just a few: universality, timely access to good quality care, equity and solidarity. We also share challenges, some acute, such as COVID-19 crisis and upcoming challenges of climate change, and some already chronic, such as growing burden of NCDs, workforce migration and shortages, and implementation of digital health. During the COVID crisis, we have proven that we can assure most appropriate response if working together. Joint procurement of vaccines, digital COVID certificate, REACT EU, as well as guidance from ECDC and EMA were representing most valuable support to member states in dealing with this all-encompassing crisis that was endangering sustainability of our health systems. The European Health Union, an initiative for the future, and the financial mechanisms such as Recovery and Resilience Facility Instrument, EU for Health, and other support mechanisms are a guarantee that we will approach future crises much better prepared. As an example of successful cooperation before COVID crisis, we could mention our common work within several joint actions against cancer that resulted in improved screening methods, tools, and guidelines in many of our countries. The new Europe's Beating Cancer Plan, again, is an assurance that ambitious next steps will be taken to further reduce the burden of cancer. During the conference, several good practices of collaboration at the level of EU will be brought to our attention. Based on ambitious goals, our countries have used different EU support mechanisms to assure deployment and implementation of innovative solutions in primary health care, long-term care, e-health, mental health care, and in many other areas of health systems development. Some of the countries made significant investments in health systems transformation. While doing so, they managed to successfully mobilize financing and combine different EU instruments. Collaboration at EU level is an enormous opportunity and an added value in looking for innovative solutions to make our health systems more resilient and responsive to the new needs of our population. There are several examples worth looking at and learning from them. Some are relatively local, such as cooperation of neighboring regions across borders. Some examples affect whole systems, such as how to reform our systems to ensure efficient and integrated care, or to make best use of digital health technologies. The first day of the conference is meant for reflection, while on the second day we should focus on new opportunities for strengthening health systems. Let us be clear. While for many years we were advocating for more resources for health, the COVID crisis has contributed to better understanding that investments are needed in the health sector. Substantial funding resources are now available, and it is up to us to use them in the most meaningful way. This will require additional capacities in our countries, but also support from the EU in navigating through available tools, mechanisms, and instruments. The conference aims to address the untapped potential for more effective use of existing EU resources and seeks to improve their use to support health system strengthening. In particular, I'm looking forward to the discussion with my fellow ministers tomorrow. As a hospital director, I could very well identify the problems in the health system. However, for deploying appropriate solutions, strategic and innovative system transformations are required. I believe that we, ministers of health of EU member states, confronted with similar challenges in diverse health systems, have the responsibility to use this window of opportunity in this regard. It has been acknowledged at many occasions that resilient and responsive health systems are key for sustainable development. I'm glad that tomorrow we will have a privilege to listen to Mario Monti, the chair of the Pan-European Commission on Health and Sustainable Development, on how to integrate various endeavors of our societies to achieve better health of our populations and support development. To conclude, I would like to express my gratitude to high-level political representatives for joining us and contributing to the conference. Sharing common aspirations, we have organized this conference in cooperation with the European Commission. The Commissioner for Health and Food Safety, Stella Kyriakides, is here with us today. Tomorrow, we will be privileged to listen to Elisa Ferreira, Commissioner for Cohesion and Reforms. I'm also happy to announce the presence of my colleague, Boštjan Koritnik, Minister of Public Administration, who will address us tomorrow. I wish all of us fruitful discussions and look forward to interesting exchange of good practices already in place and suggestions for future developments. Thank you.
Thank you. This was the Slovenian Minister of Health, Mr. Janez Poklukar. From Ljubljana, we now head to Brussels, where we're joined by the EU Commissioner for Health and Food Safety, Madam Stella Kyriakides. Thank you very much for joining us, Madam Commissioner. You have the floor.
Thank you so much. Thank you so much. Good morning, everyone, and thank you so much, Minister Poklukar, ministers, distinguished guests. It's a great pleasure to be able to join you here today. And let me first of all start by thanking Slovenia for putting health systems front and center during its presidency. Health systems resilience is a crucial component in the European Health Union, and all our efforts are to build a stronger and more equal societies. It starts with good crisis preparedness and management capacity, but it does not stop there. It covers other fundamental elements like sustainability, effectiveness, and accessibility. And COVID-19 has shown us exactly what can happen when health systems are unprepared and when health systems are lacking resilience. Health systems have been forced to divert resources to manage the high demand for COVID-19 treatment. And this has led to the postponement of other crucial interventions, such as in cancer screening and treatments, and we're already seeing the results. So building resilience is going to help us to avoid this scenario again in the future. It will help us to prevent disease, to improve conditions for patients, and ultimately, and most importantly, to save lives. The question then is how? And the Minister has already touched on some of the initiatives of the European Commission. We need reform, we need investment, and we need to work together. The European Union offers many tools and funding opportunities. And as today's conference will highlight, a number of actions under the European Health Union will help member states to strengthen their health systems. Stronger cooperation between member states combined with technical support and financing from the EU programs can be a recipe for success. Many countries in Europe are already reforming their health systems, and member states are putting more emphasis now on disease prevention, on shifting to primary care, on integrating care around people's needs, and on making a much wider use of digital technologies. We'll be hearing later today about important health reforms in Slovenia, in Finland, in Austria, and in Czechia. Innovative reforms typically sometimes start small with pilot projects, but getting these steps in the right way from the very beginning is key. However, real change happens when we move pilot projects to wider scale actions. And to do this successfully, I believe we need two things. First of all, we need sufficient investments, and secondly, a know-how and capacity to design and implement innovative reform. So let me share a few thoughts about investments first. The EU has several tools to support investment in health systems thanks to its budget and the next generation EU recovery package. I want to touch on three of them right now. The cohesion policy funds, plus two programs that emerged as a direct result of the pandemic, the Recovery and Resilience Facility and the EU for Health program. For the cohesion policy funds, I will not go into detail here because Commissioner Ferreira, my colleague, will be sharing this tomorrow. But just to say that between 2014 and 2020, more than 7,000 health-related projects were launched with over 8 billion euro in funding. Secondly, under the Recovery and Resilience Facility, the centerpiece of Next Generation EU, member states plan substantial investments in their health systems to address long-standing challenges and drive the recovery from the pandemic. Most have now submitted their recovery and resilience plans. These include over 50 billion in health investments, which cover from hospital and digital infrastructure to mental health, disease prevention, and many others. And thirdly, and importantly, the new, for the first time, standalone EU for Health program with a budget of 5.3 billion will support actions to improve health in the EU, to tackle health threats, to make medical products available and affordable, and strengthen health systems. And this is the first time that we have such a large budget and a first-time standalone health program as EU for Health. So now it is up to us to design and implement reforms, and to do this we need to work together. At EU level, we have several mechanisms which help us to translate the knowledge and the guidance into practical support for health authorities. The EU Beating Cancer Plan is one of my priorities in this mandate. We have already launched the new Knowledge Center on Cancer. It's the new first flagship action delivered. The Resource Center for Integrated Care on EU Health Platform, and a portal for best practices covering non-communicable diseases. And later on, you will have the opportunity to hear about the Steering Group on Health Promotion, Prevention and Management of Non-Communicable Diseases, a group which transfers best practices and political priorities to meet the needs of member states. Through this process, we have launched a joint action to transfer best practices in integrated care, and we're planning another action to transfer best practices in primary care, again under the EU for Health program. And primary care, I know, is a very strong component of the Slovenian health system, and I believe that we can expect Slovenia's experience to feature jointly in this joint action. Ladies and gentlemen, with COVID-19, we have seen how important it is to have resilient and strong health systems. But we have also seen that this crisis provides us with an opportunity to move forward, to move together. It has showed us the strength of solidarity and cooperation. We have a successful EU vaccine strategy. This is the epitome of success, of collaboration and solidarity, with an EU vaccination strategy that has worked, delivering vaccines to its citizens, leaving no one behind, whether from a big or small member state. We're already moving forward, having already launched an EU therapeutic strategy for COVID-19. So we plan to continue in this spirit of working together. We plan to stand ready to help member states to learn from best practices, to design investment plans, and to make the best possible use of available EU instruments. I look forward to working with the Slovenian presidency, with the minister, on the outcome of this conference, because I believe that working together, we can build back better. Thank you.
Thank you very much, Madam Commissioner, for your contribution to the conference, and we hope to see you soon in person here in Slovenia. So good luck and take care.
Thank you. Thank you so much.
And now it is my honor to announce the keynote speaker for the opening part of the conference, Dr. Hans Kluge, the Director of the World Health Organization Regional Office in Europe. Dr. Kluge is here with us in Ljubljana and will speak about the importance of European partnerships and in implementing innovation and the cooperation between WHO and the EU in strengthening European health systems.
Dear Dr. Poklukar, Poklukar, Minister of Health of Slovenia, dear Commissioner Kyriakides, Excellencies, Minister of Health, Professor Mario Monti, Chair of the Pan-European Commission on Health and Sustainable Development, Dr. Figueras, Director of the European Observatory, colleagues and friends. Let me first and foremost warmly congratulate the Minister of Health, Dr. Poklukar, for a very successful start of the Slovenian EU presidency. We have very fresh in mind what the Slovenian EU presidency pulled off in 2008, not at least being a pioneer on cancer prevention and control, and we have no doubt that this presidency will be equally successful. Today, 539 days since the first COVID-19 case was detected in the WHO European region, registered cases are 57 million and the deaths are 1.2 million. The Delta variant continues to spread, and we anticipate that in August, the WHO European region, which encompasses 53 member states, will be Delta dominant. Cases are again on the rise and the overall deaths are likely to increase soon. Fact is that in the larger pan-European region, only 1 in 4 of the nearly 1 billion people that live in the 50 countries is fully vaccinated. As we discussed with the President of Slovenia yesterday, it is absolutely imperative that we learn the lessons from 1 year ago, because the 3 factors that cause a resurgence are present. One is the fast spread of the Delta variant, which is going to hit even harder. Second is lifting of social restrictions. And the third is still a moderate pace of vaccination uptake in the larger region. However, the positive news is that now, unlike a year ago, we have a very powerful toolkit of effective vaccines which are the way out of the pandemic. At the same time, fatigue has set in and there is uncertainty in some contexts about the continued application of public health and social measures, as well as a debate, in fact I would stress a false debate, between doing what's right for health and what's right for our economies. And I'm sure Professor Monti tomorrow in his closing speech will come back to this very important point. But it means that our health systems continue to be challenged. Issues we faced at the onset of the pandemic, the system readiness, the surge capacity, ICU bed numbers are again coming to the fore. Hospitalizations are on the rise due to the Delta variant and the prospect of an epidemic of what WHO refers to as a post-COVID condition, which casts a growing shadow. So a year and a half into the pandemic, we need to ask whether this is how we want to continue. What we have learned about the resilience of our systems, is this our new normal in respect of health systems and services? Are these the tools we want? As many of you know, the concept of health system resilience is not new. But COVID-19 stresses that we have not yet put resilience into practice. At the same time, the pandemic shows us unique opportunities of promoting resilience, most notably within service delivery, data management strategies, and digital health. Health system resilience typically focuses on understanding preparedness and the ability to absorb, adapt, and transform in coping with acute shocks. But it also includes the ability to evolve, to learn and transform, ideally improving future performance. So COVID-19 is a watershed moment to which the only response can be a radical, disruptive rethinking. Our understanding and commitment to resilience needs to drastically change. Working with member states and in collaboration with the European Observatory on Health Systems and Policies, WHO Europe is studying what COVID-19 has taught us: resilience. Of the countless lessons, let me dwell on 3 key ones, which are fully in the spirit of the Ljubljana Charter and the Italian Health System Charter. It centers around 3 I's. The first I is invest. We need to make the case for sustainable health system investments. The economic and social return is multiple. It's obvious. As we discussed with the Minister of Finance of Slovenia yesterday, the health system itself also needs to do its share. So before we ask more money for the health, we also have to ensure more health for the money. And a key factor here is prevention. Prevention, which is at the core to tackle our big health system issues and risk factors such as tobacco, alcohol, physical inactivity, and unhealthy diets. The second I is the I from include. We need to double down on universal health coverage so that everyone, everywhere, has access to health and financial protection. Impoverishing payments for health should be a thing of the past. No country in the region has more authority to talk about this than Slovenia, which has the lowest out-of-pocket payments in the region. Universal health coverage in our regions is particularly an issue that people are being pushed into poverty due to the fact they can no longer afford innovative medicines for chronic diseases, for non-communicable diseases. And that's why we established, with the Minister of Health and Care Services of Norway, Bent Høie, the Oslo Medicines Initiative to ensure sustainable access to affordable, quality, innovative medicines to everyone who is in need. The third I, last but not least, is innovate. We need to harness innovation and systems to meet the people's needs. Bring our systems up to date, use them to fight inequity, foster patient participation, enhance quality, and health worker protection. Our systems can never deliver people-centered equitable services unless they innovate. It is through innovation we maximize health outcomes and minimize the social divides, as well as improve our current pandemic response and the future ones. Both soft innovation, meaning first and foremost innovations in how we deliver services based on a strong primary and community care. I had the unique opportunity to visit this morning the Ljubljana Community Healthcare Center, including the first simulation center I ever encountered based on primary healthcare. The trust in primary healthcare is key, and that's what I saw, and congratulations, Minister Poklukar. COVID-19 has seen countries acknowledge the need for digital health and data solutions. Digital health and data innovations have helped improve our responses, allowing us to build on the momentum and assure sustainable mechanisms to support digital transformation and adaptations of systems for future challenges. To fully leverage the value of data and digital technologies, we need 4 things. First, to ensure that we develop digital health services that do not cater only to the privileged ones who can afford them or exacerbate existing inequalities. Technology is meant to democratize health. Technology is not meant to democratize inequalities. Second, close data gaps and have reliable information systems that allow timely and accurate resource allocation. Slovenia's national open data portal, OPSI, is a great example of an innovative, free digital solution. Third, invest in and adopt digital tools for use in emergencies, essential health services, and crucial to unload our aging and migrating health workforce. Fourth, work harder to establish trust in digital solutions and do so by being cautious, consistent, safe, and inclusive. As countries respond to and recover from COVID-19, now is the moment to ensure an inclusive transformation with coordinated and comprehensive strategies that bridge digital divide. Now is the time to learn what has worked well and bear in mind that digitizing a broken process only gets you a digitized broken process. So what are the key takeaways? Digital health has quickly moved from optional to essential. The role that governments, civil society, academia, and the private sector have in bringing emerging innovations into health systems has been reinforced. This is a wake-up call to digitize systems and develop data infrastructures to support early warning and response. Throwing in new digital tools will not be enough. We must focus on re-engineering processes so they leverage the value of data. A final thought on future health system resilience. It is not simply a matter of improved digital capacity and data management, nor is it only about ICU capacity or pandemic preparedness. It is about protecting the health of the people. Because addressing resilience is part of a wider commitment to health. A healthy system is always going to be more resilient if those it represents are healthy and resilient themselves, including the mental health of the people. Next week, with the Minister of Health of Greece, Vasilis Kyriakides, we will convene the Athens Summit on mental health, not at least of the workforce and the youth. But neither is the idea that we are only as strong as our weakest link, simply about the strength of national health systems and how they work together. It is about lifting the weakest in society. It is about leaving no one behind. This means addressing the cause of the cause, as to why so many people have been infected, why those already in a precarious life situation bear the greatest burden. Remember that COVID-19 is a disease of inequality. In the future, any health system resilience against a pandemic will be predicated first on our overcoming inequalities. And that's the core of what Professor Mario Monti, as the chair of the Pan-European Commission on Health and Sustainable Development, will talk about, and I'm very indebted that Professor Monti made the effort to come here and join us in person. I would like to thank our host, Slovenia, the President of the Council of the European Union, a champion of leaving no one behind. WHO Europe is supporting the member states to consider the well-being economic model for future development and recovery planning, and I'm thrilled that Slovenia has shown interest to be among the pioneers. We are very thrilled to see health prioritized in the new European Union multi-annual financial framework and many other financial instruments. Now is the moment to put this opportunity into the most effective way, and I trust that this conference today and tomorrow will pave the way for this. Let me finish with a well-known Slovenian saying. Kar lahko storiš danes, ne odlašaj na jutri. What you can do today, do not postpone to tomorrow. Hvala.
So thank you very much, Mr. Kluge. That was your dynamic, resolute style with a perfect touch of Slovenian. So welcome again. Thank you very much. That was Mr. Kluge, the director of the WHO Regional Office for Europe. We continue with the presentation of the Presidency's publication, and another prominent speaker at this event, Mr. Nicholas Fahy, expert advisor on innovation and implementation. He's senior researcher at Nuffield Department of Primary Care Health Sciences of the University of Oxford. Mr. Fahy is unfortunately not here in Ljubljana, but we're glad to have him with us, at least online.
Good morning, colleagues, and thank you, Chair, Minister, Regional Director, Your Excellencies, dear colleagues, ladies and gentlemen. Indeed, I regret that the travel restrictions in place mean that I can't be there in person, but I'm honoured to nevertheless be able to make this presentation at this important event of the Slovenian Presidency. It's a personal pleasure to be able to make a contribution to this presidency, as I was able to work closely with the previous Slovenian presidency that relaunched the European Union's work on tackling cancer, and which gave us all an example of what could be achieved by working together. And I'm very glad to be part of this presidency and helping to support the presidency in taking forward those ambitions now. So the context that I want to introduce in the next few minutes is around mapping what support the European Union provides for developing and strengthening health systems. We should underline at the start that within the structures of the European Union, health systems are primarily the responsibility of the member states, not the European Union itself. Nevertheless, the European Union provides an increasingly shared context. So this comes through areas such as policy orientation, such as through the European semester, through potential support that can help to shape and strengthen health systems through instruments such as the cohesion funds, through collective action, such as through joint procurement, whether of personal protective equipment or vaccines, as we've seen during the pandemic. And so this reflects the wide range of EU tools that have grown up. But because they've grown up over time and reflecting the fact that the primary responsibility for health systems lies with the member states, there is actually a very wide range of tools scattered in different places throughout the EU's architecture. As Commissioner Kyriakides said in her introductory remarks, the EU for Health programme is one of the first times that the EU has had a specific health programme on such scale and dedication. But that's not to say that there aren't many other tools which are potentially available. And so the Slovenian presidency asked for the European Observatory to support the work of the presidency by producing a mapping of European Union support for improving health and care systems. And that is the draft policy brief that many of you will already have had a chance to look at, which was circulated as the background document to this conference. I'd like to emphasize that what we've circulated and what we have prepared at the moment is still a draft. It will be revised after this conference, precisely because there are such interesting examples that we will be hearing about over the next 2 days, and we will be making sure that we update the final policy brief to incorporate material from this conference. Our thanks to the Presidency and to the Commission for their help in preparing it. I'd like to, in particular, thank Maya Matthews and Lukianos Gatsoulis of the European Commission, and Vesna, Kerstin, Petrič, and Urške Eklavic from Slovenia, as well as my colleagues Nicole Mauer and Dimitra Pantelli within the Observatory. Of course, all errors and omissions in this still draft policy brief remain our responsibility. In order to understand these different tools, it's useful to think about what kind of processes different tools can help. And so let's start with the idea of a process of change. And you can see here a four-step process of change, starting with ideas, moving through plans, tests, and implementation. By ideas, we mean those first overall aims. What might we try and address? So if we were to think, for example, of a topic such as integrated care, we might have an overall policy aim for a health system of strengthening integrated care, drawing on ideas of how it's worked elsewhere, different structures which other countries have put in place, perhaps. Of course, our system will always be different from other systems. Every health system in Europe is unique, and so we must turn these different ideas into detailed plans. How might it work here? What actors might need to be involved? What's our geographical distribution? Who are the different, what are the different financing mechanisms? What are the different needs that we need to meet? Once we've made our plans, plans never quite work out as we would like them to in practice. We need to test things, we need to pilot them, we need to check how things work in practice. And then once, hopefully, we've tested and refined and adapted towards a solution that we think can work in practice, we want to scale this up and bring this into large-scale system change throughout our health system. If we then look at how different EU instruments fit into this process of change, we can break them down according to this very general overview. And so we see several different key things here. We see that there are instruments at every stage of change, whether it is at the stage of the initial policy orientations, for example, which might come from tools I've mentioned, such as the European semester or through Commission communications, whether it's through funding, whether it's through information, whether it's through technical assistance. And the distinction we make here is that information is something which is general, which might be universally applicable. Technical assistance is when someone helps you provide adaptation of this general principle and general information to the specific context. It's also important to note that this is only a general overview. Many of these tools make different contributions that span different stages of change. For simplicity, they're categorized here according to their main contribution, and there is more detail on the full range of support that is offered under each of these different tools within the policy brief. But let's go through some of these in more detail. So if we look at the policy level, the European Union sets out overall ideas and directions for health system change through processes in particular such as the European semester, which follows an annual cycle. And we've seen during the COVID pandemic that health recommendations, which were frequent before, have now become central and focused on ensuring the resilience of health systems, as indeed the Commissioner referred to earlier in her remarks. There are also then more specific EU policy statements around areas such as Commission communications. You see a few examples here, different strategies, recommendations of the Council of Ministers. Previously, we might also have talked about the open method of coordination, method of intergovernmental cooperation, which those who have followed this area for many years will be familiar with, but this is now less active in health. And I referred earlier to the work of the previous Slovenian presidency in relation to cancer. And that's an example, I think, where setting out an overall policy framework, a policy statement at European level has mobilized many actors, many resources, and brought about change in many different health systems over subsequent years. Funding, we see many different areas of EU funding through such as the cohesion funds, the recovery and resilience facilities specifically brought in to help boost recovery after the COVID pandemic, and which again is being shaped at through different national plans. One of the key points to point out here is that it is not only the European level which determines how these different funding tools are used. An enormous amount is shaped by the choices that member states make themselves about what priorities they themselves see. And health is sometimes one of those priorities, but historically has not always been one of those priorities. For a health minister or a health ministry, therefore, this creates a two-level process. One in ensuring that it is possible to access these tools at the European level, but also at the national level, ensuring that you have the support of colleagues, and that's not always straightforward, and something I think that we will hear more about during some of this afternoon's presentations. These tools principally provide grants, or at least parts of grants, in order to help provide funding within member states. There is also the European Investment Bank, which provides loans, but very low-cost loans, and unlike the cohesion funds and the more targeted funds of the European Union, which are focused on the less developed parts of the Union, the European Investment Bank provides funding support that covers the whole of the European Union and indeed beyond. If we turn to information, there is indeed the EU for Health programme, which the Commissioner referred to, and the EU for Health programme provides a very wide range of different types of support, provides ideas, models, cooperation platforms, reports, expert advice through various expert committees, which might be very narrowly focused on particular scientific questions, or might be providing very broad questions, such as providing opinions on health system performance assessment or how best to invest in health systems. The research programs, Horizon Europe, one would think you might know what a research program does. It funds research programs. But actually, Horizon Europe funds a broader range of activities than one might at first sight think. And one could highlight particular tools such as the development of innovative solutions for problems which health systems have identified through pre-commercial procurement, which is intended to bridge the gap between initial basic research and solutions that are really applicable for member state health systems by providing a route through that development and innovation process towards an identified social health goal. There are also information platforms provided by different EU agencies in particular. Many will be familiar with the European Centre for Disease Prevention and Control and the European Medicines Agency. There is also a lot of information from other relevant health agencies, such as the European Monitoring Centre for Drugs and Drug Addiction. Indeed, across all of these different areas, this is an instance where both, for example, the health and the research programs have huge numbers of projects which are in principle available from online databases, although there are so many that it can be hard to identify what's relevant to a particular challenge for a particular health system or a particular topic. And then, in the last instance, technical support. So this is the bridging, if you like, between the general possibilities which are available and the specific challenges and issues facing individual member states. A key instrument here is the technical support instrument. This was a successor to the Structural Reform Support Service instrument, which was itself the successor of the different task forces which were developed under the bailout programs, which provided financial support to many different EU countries following the 2008-9 global financial crisis. This technical support instrument helps member states to develop their own national strategies around areas such as integrated service provision reform in Estonia, or health systems performance in Latvia and indeed in Slovenia, or primary care reform in Austria, and we'll be hearing more about some of those examples later. One of the distinctive things about this particular EU support instrument is that it provides support across all of these different stages of change, although that does come with a slight catch, which I will come on to in the next slide. From the loans side, there is also the InvestEU Advisory Hub, which is a joint initiative of the European Commission and the European Investment Bank, and which provides technical assistance to supporting all stages of developing and implementing investment projects, drawing on funds from the EU and the EIB in particular. So there is some support to help national systems be able to navigate this range of different tools and adapt them to their own local circumstances, although neither of these two specific tools is specifically focused on health. So there was a slight catch. It's important to bear in mind the different size of these different tools. So this graphic is intended to give you a rough perspective on the comparison of the different sizes of funds which are available through these different tools. It's not an exact comparison, because in some instances we're describing for most of these, we're describing the overall funds which are available, and of course they don't only fund health. But what you can see is that there are very large differences in size between different tools. And what you might also see is that both the technical support instrument and the only specific program dedicated to health, EU for Health, are relatively small in comparison to the other tools available. So as this makes clear, in order to access the full potential of financial support from the European Union, countries must do two things. They must reach out beyond the funds which are specifically dedicated to health, and in order to make best use of the full range of these different tools, they must combine different instruments which have different aims in support of their own domestic reform programs. So you will find much more detail about all of these different tools within the policy brief itself. We've gone through different topics in quite some detail. We have not provided complete detail on every possibly relevant project because there are quite literally thousands of them, but you will find some illustrative examples in there and information about where to find further resources. Rather than going through that in detail, what I'd like to do now is provide the overall evaluation, give you a flavor, if you like, of what we found when we did this overall mapping of European Union tools to help support health systems. And the first thing to say, given the primary responsibility of the member states for this area, is that the EU does have a lot of tools that can support health systems. For most of these tools, they're not primarily for health, and for many, health is not one of their primary objectives. That reflects the distribution of responsibilities between the EU and the member states. But it does also mean that this creates an additional need to bridge between health objectives and the objectives of the tools concerned when seeking to make use of the different tools that are available. The second point to make is that, of course, different health systems have different needs and different interests in having EU support. We have seen, for example, that with the cohesion funds, formerly the European Structural and Investment Funds, these funds are specifically targeted on with a relatively lower level of economic development. And because those tools are one of the key sources of funds from the EU for helping to strengthen health systems, that means that the key benefits, if you like, of that particular source of EU tools have gone towards the less economically developed countries within the EU. And many of those countries have wanted to make more use of European tools than some other countries within the EU. So different systems have different needs, and also access to different potential types of support means that when looking at the use that is made of these different tools, we need to bear in mind this country by country difference. In order to address each of those different stages of change that I described earlier, the third point is that different tools will be needed at each of those different stages. If you remember that overall graphic, there are tools in every column, but they provide different types of support. In order to go the whole of a process of change, to go from, if we go back to the example of integrated care, to go from the first ambition of saying we want to strengthen integrated care in the specific plan, them, and then through seeking and implementing them, that will mean involving and combining different tools at different stages. The scope for collaboration between member states, there's also scope to involve other actors, such as the World Health Organization, which has also provided support to member states in making best use of these tools, for example, in Greece. And we've just come to the start of a new programming period, and therefore now is an extremely timely moment to consider how to make best use of these tools, especially also given the additional pressures from the COVID pandemic. So these are the overall points. The primary responsibility for health systems lies with its member states, but the EU can help. There's a wide range of tools which can help in different ways and which need to be put together in different ways. And there is scope for member states to do more in working with each other and with the European Union in order to use of these processes. My thanks again to the colleagues involved in preparing this brief. I hope that you find it useful, and I hope that it provides a useful basis for what I'm sure will be an extremely interesting set of discussions at this presidency conference. Thank you.
So thank you very much, Mr. Fahy. You will be moderating a high-level session and panel this afternoon, so we're happy to see you soon. But our first panel will focus on innovation and innovative solutions at the national level. So I'm really pleased to give the floor over to our first expert panel host, Mr. Josep Figueras, Director of European Observatory at Health System and Policies.
Good afternoon. I'd like to add also my welcome to this wonderful conference, and above all, my deep thanks for the privilege, my privilege to be here, the privilege of the Observatory to work closely with the Slovenian Presidency, closely with the Commission, to prepare some of the evidence that is informing this conference. The stage is set. We heard from Commissioner Kyriakides, from Regional Director Kluge, from Minister Poklukar, and from Professor Fahy. We heard the systems are important, health systems are important. We need to strengthen those health systems, and indeed, the pandemic has reminded us about the importance to strengthen those health systems. We heard already some of the innovations that are put in place. We'll hear a lot about innovation these days. Not only the gadget innovations, but the organizational innovations much more important. But much more important of all, what we'll hear in this conference is implementation, is the how. When Regional Director Kluge was telling us about the 3 I's, indeed, the 3 I's that are very much underlining this conference today, is the innovation, is the investment, and indeed is the inclusion. We heard how we need to have not to leave everyone behind, and the pandemic has left many people behind. But those three I's, we're adding a 4th I, the I of implementation. So the whole conference of implementation is on implementation, and this first session, we call it Implementation, Deploying Innovative Solutions at National Level. For that, we are very lucky. We're going to start with 2 countries. 2 countries that we're going to hear from these 2 countries the complexities about introducing reform, about the kinds of priorities, the kinds of ways they reacted to the pandemic, and the complexities and lessons as well about implementing those innovations and those reforms. And in that sense, it's a real privilege to introduce Vesna, Kerstin, Petrič, the Director General here on Public Health here in Slovenia, as well as Lisa Maria Voipio-Pulki, the Director General in Finland. They're both leading professionals, they're both leading civil servants, but I must confess, as there are a few people here in the studio, they are to me role models. These are 2 individuals from whom I learn a lot about strategic leadership, about vision, about planning, and about their implementing. So we're very lucky to have them telling us how they managed in their countries to implement some of these reforms. Then We're very lucky indeed as well to have Francesca Colombo, the director of the health division of the OECD, who then is going to take a broader perspective. It's going to take a perspective, a cross-country perspective of reforms. She's going to look at the experience that we have had during the pandemic, how the countries have responded to that pandemic, what kinds of innovations, and she's going to draw some broader lessons across the OECD on this implementation. And finally, last but not least by any stretch of the imagination, we'll have Mario Nava. Mario Nava is the Director General of DG Reform, a relatively younger DG within the Commission, who's going to tell us what we heard already from Commissioner Kyriakides, what we heard from Nick Fahy, the kinds of support, the kinds of tools, the kinds of instruments, but focusing on the instrument he's leading, which is the technical support instruments that is providing to member states. So I'd like now to introduce the first speaker. We're going to go to our host country here in Ljubljana right now with Vesna, who's going to tell us how, Vesna, how you've been implementing reform, what kinds of priorities. Welcome.
A warm welcome also from my side to all the participants, and thank you, Josep, for a very kind and nice introduction. My task today is here to share with you Slovenian experience with innovating, also including and of course investing, and most of all implementing for strengthening primary health care. In my country, oops. Sorry, the presentation is not there. We would need the presentation.
As the presentation is set up, I was wondering, Vesna, it's a question that could be the beginning of your presentation, because as I said, and you know that, I admire the way you've been working, the way you've been operating, the way you've been introducing reform. It reminds me of Bill Clinton during his campaign a long time ago, it shows my age, which he said, it's the economy, stupid. In your case, it's not stupid, of course, Vesna, but it's leadership, stupid. Isn't leadership what really makes a difference in transformation and implementation? Isn't it? And you are that leader. I've seen you working on tobacco, working alcohol, that excitement, that pushing forward, that transformation, which is in the instruments we're going to talk about. How do we replicate, how do we get that leadership to push reform, to push transformation?
Well, I think that it's really important to understand that leadership is not only on the top. All of us working in a certain area and creating certain environment to be then successful have a possibility to lead. And here I'm saying, of course, political leadership is most important, because without political leadership it's very difficult to move things. But it's also important that we understand that those people implementing actually any reform also have to be considered as leaders when it comes to implementation. And this is often forgotten, and for this reason very often people don't feel like, you know, support change, because they don't feel this change is theirs. But if you consider them leaders in the reform, all of those that I mentioned and all those between, then I think this is a precondition for a really successful change, transformation in the health system.
Can we create leaders, Vesna? Can we train leaders? Or they're just there, they're born, they're genetically made to be leaders? It occurs to me that as we're talking today about reforms, about support from EU, technical support, funds and so on, there's such a capacity to learn from each other, to train leaders in this European Union of ours. Don't you think so?
Yes, and I think training is important because you have to know a lot about, for example, health systems if you want to be a leader in this area. But it's also important, devotion to the area. So first of all, you have to have this ambition to do something good for the society in the area where you are, in this case, health systems.
So we need to give opportunities to people with ambition,
yes,
to train them abroad, to exchange with other countries. Don't you think we need to push for more? There are good, important programs there. Shouldn't we use them a bit more effectively to get this beauty of professionals crossing borders and learning from each other?
Well, I know several opportunities there. One certainly is the Gastein Forum and Young Gasteiners, where we actually, as European Union, invest in young people and prepare them for the leadership. There is also, for example, summer school that you are organizing every year, where people can learn, in particular, young people about the health system. And there are other opportunities that are offered by all our universities, certainly. I think it could be more, but I think to use these opportunities would be already very efficient. The problem is that we don't use them as much as we could.
As we should, exactly. I think that would be a very important lesson for this conference today. If the slides are ready, I'll ask you to continue with your presentation, because I know about the exciting reforms that you've been putting in place in Slovenia.
So I hope the presentation works now. I already warmly welcomed you all. So I'll continue by saying that in my country, we are very proud of our health systems. And also with some sound criticism, of course. There have been important improvements. The life expectancy at birth has been increasing since 2000 and is about the EU average for several years now. Much of this could be contributed to decrease in mortality in cardiovascular diseases. Cancer is still a challenge, but as you will hear tomorrow, there is a good progress, and the recent data show that we are on the right path. Being a country with high prevalence of suicides and accidents, we are happy to see the decreasing trends in mortality related to external causes. There are some areas where still a lot needs to be done. Alcohol contributable deaths are still high, and we will have to work hard to assure political will and capacities to tackle this risk factor. On the other hand, tobacco policy is a success. Slovenia is one of the countries where tobacco directive and FCTC, including plain packaging, for example, have been rigorously implemented, and the numbers of smokers, of course, reduced. It is important to understand at this point that in terms of health spending, Slovenia is below the EU average. Our strength has always been community-based and strong primary health care, ensuring access to family physicians, pediatricians and gynecologists with no referral, and including community nursing, dentistry, physiotherapy and diagnostic services. An important progress has also been made by introducing organized screenings for various cancers, where investing in communication in particular paid off, and we can now observe very high responsiveness and participation rate. Strengthening primary healthcare has been a key strategic priority of the last two national healthcare plans. The aim was to better integrate primary healthcare and public health services, to improve access to preventive services and screenings, in particular for vulnerable groups of population, to increase health literacy, and to invest in the workforce and appropriate skill mix, as well as, of course, in facilities where this is appropriate and necessary. Reducing inequalities, however, is always the overall goal of any transformation in health system in Slovenia. In transforming its health system, Slovenia has always looked for opportunities in international cooperation. We have analyzed our health system as a whole and primary health care in particular in cooperation with WHO and Observatory for Health Systems and Policies. And we have also used at the time available financial mechanisms of the EU and other mechanisms to reform our primary health care. Transformation has been done in two steps. First, we used Norwegian grants for piloting the new model, and later on, we used cohesion funds for supporting implementation in 26 community health care centers out of 64. Implementation will, of course, continue until all health centers will introduce the new model with preventive services and health promotion close to where people live. What exactly has been done? Perhaps it is best to look at the patient pathway. Preventive checkups have been introduced into family physician and pediatrician practice. For this, the teams have been strengthened by additional registered nurse responsible for chronic patients in case of adults and preventive services. The nurse can refer patient to a health promotion center that was created with the purpose to serve patients in dealing with their risk factors, such as smoking, harmful alcohol consumption, or obesity. To assure participation and support to those most vulnerable who very often, for various reasons, do not attend preventive services, health promotion centers were encouraged to cooperate with NGOs, social care services, and schools in the local community. The model and investments have given very good results. 19% decline in premature mortality between 2007 and 2015 is in many ways a result of these efforts. Almost 1 million adults, or half of the adult population, were already screened for lifestyle risk factors. 50,000 patients annually attend interventions in health promotion centers. The success factors, we think, were the following. First of all, strong political commitment. I said before that we have adopted strengthening primary health care with preventive services as one of the key priorities of our national plans. Involvement of key stakeholders was also important. And before I was mentioning that we understand that key stakeholders are in particular those who then implement the innovation. Also, of course, financing is crucial. And to us, it was very important to link public health with primary health care and make them work together. Countrywide implementation is very important because, good models should be perceived by the whole population as something that they will be entitled to when, of course, pilots are done. And this we found important, and also the motivation was high. Development of workforce, we have to invest in the workforce and capacity building, even, infrastructure is important. But what we think is really crucial is participation of local communities and also organizations, including civil society, because we wanted to make sure that vulnerable groups, as I said before, those that very often don't attend our services will be involved appropriately. And not least, but I have to mention it, media strategy and campaigns to promote the new ways of working is also very important. To conclude, let me share with you what we have learned when trying to develop in primary healthcare new transformation. Innovative solutions that matter to people and respond to their needs are the ones with most potential for implementation. Otherwise, we can have very good models which are piloted, but they won't work. And if you at the start, really focus on the needs of the people, this will make it then much more possible to be implemented. And also participatory planning, including people working in primary health and also patients, community engagement and transparency are the key building blocks of successful implementation. Thank you very much.
Thank you very much to you, Vesna. That was beautiful. That was brilliant. Key points here. Let me actually attest to the fact that primary healthcare in studies and benchmarking and ranking countries, Slovenia is at the very top. And one of the aspects I think we need to learn a lot, and you mentioned, is the linkage you manage between healthcare and public health. The way you manage to bring these two elements that are in the principles of Alma-Ata and the principles of the Astana, the New Declaration, are so difficult to implement in practice. It seems to me your lessons at the end are very important lessons, and we learned these lessons the hard way as well with COVID. It's not just a luxury. Political commitment is not a luxury. Communication is not a luxury. Involving and participating is not a luxury. So it's beautiful that you wrap up your presentation with these very, very important lessons. Vesna, I'll bring you back. We'll have a debate, all the panelists, which reminds me, colleagues, those who are out there following us, we have a very active chat box moderated by Nicole Maurer, my colleague here, and Dimitra Pantelli from Brussels, and we'll bring you during the debate your questions, your points, your contributions. But not only that, we will collect all this contribution. I will make it part of the proceedings of the results of this conference. Now I'd like to bring in from Helsinki, Lisa Maria Voipio-Pulkki, Director General and Chief Medical Officer in Finland, to give us a sense, give us an idea, again, with short time, I'm sorry, Lisa Maria, about the reforms, the kinds of key reforms that you are putting in place in Finland. Welcome, Lisa Maria.
Thank you.
Thank you, Josep. I hope this connection works well. Can I have my first slide, please? Okay. Excellencies, colleagues, ladies and gentlemen, thank you very much for the invitation to share with you some of the ideas and experiences on implementing innovation at the national level from the Finnish point of view. I try to ask you to show my slides. Thank you. This is slide number 2. So medical innovations are sometimes seen as threats to health systems' sustainability. The Finnish experience is that promoting medical and health systems innovations can and actually should be coexisting goals. Since 2014, all Finnish governments have set the goal to us as 3 ministries and 2 major funding organizations that Finland should and needs to be a source and user of versatile and high-quality scientific research and a preferred partner in public-private collaboration in health sector research and innovation in order to be a model country of modern healthcare and even if you want to put it in this way, personalized or more personalized healthcare. So this means that over the years, we as the government have been backing the creation of national excellence centers like the Cancer Center, the Center for Brain Health, biobank-based research, and so on. And these are often backed by new legislation. So seen from the medical point of view, there has been progress, but it could have been faster. This is what many people keep telling us. Why? So I think that there is a very wise statement in the external review of this program, Health Growth Program, and I cite it. While biomedical and technological innovations have the potential to have universal impact throughout health systems, the impact they actually have depends on the accompanying organizational innovations to put them into practice. Next slide, please. Slide number 3. But over the years, we have though learned that building a medical innovation ecosystem that delivers true value has to be a top-down and bottom-up experience. In other words, a joint venture of citizens, scientists, companies, authorities, and healthcare providers. Governments and political decision-making actually do play a very important role there, but in order for us to really fulfill our role and be accountable, we need a whole lot of help. We need professional excellence, medical, legal, ICT, you name it. We need an open public-private environment. We need legislation. This is, of course, our bread and butter as ministries, and ethical principles to create established and trustworthy procedures and trust among people that we are doing something for the best for the people's health. We need a dialogue from the government with the health system decision makers on all levels and public health experts and opinion leaders particularly, in order to demonstrate that together these innovations can improve people's health and well-being and health system resilience, which is becoming more and more important all the time. Can I have the next slide? Slide number 4. Now, going back to the health systems and structures issue. Sometimes the health system, as it is not fit for the purpose to adopt useful innovations in the best possible way. And I think that this might be also the Finnish experience. We have had an extremely decentralized health system with more than 200 organizers. And now finally, the reform to merge these to something like 20 plus organizations that have the responsibility for organizing all health and social and rescue care has seen the daylight. Next slide, please. Slide number 5. Even if several of these attempts to do the reform, to do something like this, have failed politically, so the basic idea and principle of integration being the key to more responsive and resilient systems has always been there, has actually survived and matured over the years. So the key feature of the reform is structural and functional integration of all primary, secondary and tertiary health services, actually including also public health in the Finnish concept, social care and rescue services under one budget and one management. And then allocation of resources according to population needs, which would be a nationally steered process and has actually been practiced already a few rounds in the preparatory phase of the new legislation. So the key point here is learning from previous reform planning cycles to create national platforms to share best practices among the counties, because some of them have actually taken voluntary steps even before it became legally binding to create these new organizations. Next slide, please. So implementation of the reform at county level is actually a huge challenge. Of course, this is something that we really have dreamt of for a long time, and it's a huge implementation challenge, but at the same time, a window of opportunity for system-wide innovations. So how does the government now support this change? Of course, by state aid to counties for implementation of the structural and legal changes in the next couple of years or so, which is no question about it's obligatory for the present municipalities and future counties. But above all, it is important that we also together look upon the service development projects. The funding for this comes from the RRF and normal state Finnish budget means, but the purpose is to ensure better access, integration, quality, and cost effectiveness of services. These are, of course, very familiar words, very familiar concepts. But how do you really define them? How do you implement them in practice? And how you measure your success? Because these actually are the true goals of the reform, and our success is being evaluated against these goals. So to achieve this, it's absolutely necessary that we have a constant dialogue between the counties and their present representatives and the central government. You know, one size does not fit all in a country like Finland, which is geographically very vast, very big, and has sparsely populated areas and has big towns and cities. But there has to be a certain level of comparability despite these largely variable regional circumstances. So over the years and over these previous cycles of reform attempts, we have learned that integration of information systems and database management are actually keys to successful reform implementation and impact assessment. And last but not least, over the years, also the COVID-19 crisis has taught us this lesson, that even us who thought that we would have excellent patient record repositories and so on, don't have a real-time access to data that will really have the information of how our systems are working and how are they matching people's needs. Next slide, please. And therefore, I would just like to briefly scale up and draw your attention to the European Health Data Space Initiative and the TEHDAS joint action, which is coordinated by the Finnish Innovation Fund, Sitra, and is based on some of our national experiences of pooling data and legislation for the secondary use of sensitive personal information. There are 21 EU member states and 4 non-EU member states participating in this joint action, which aims at helping the member states and the Commission in developing and promoting concepts for sharing of data for many purposes mentioned here: citizens' health in general, public health, health research, innovation, also governance in Europe. We have a very rich pool of data with various degrees of accessibility. And we strongly believe that being able to synthesize, analyze, and apply data and create information and evidence is a very important clue to the sustainable and resilient renewing, constant renewing of our health systems as member states and also as international and global health community. As it is stated on my last slide so clearly in the Finnish constitution, and I always like to cite this final slide, what is our final aim? So the public authorities shall guarantee for everyone, adequate social health and medical services and promote the health of the population. Thank you, Mr. Chair.
Thank you very much, Lisa Maria. Beautiful that you finish your presentation with this reminder of your constitution. Lisa Maria, you told us about innovation. You told us about the lessons of public-private partnerships and bringing all sectors, key in COVID, key in our reaction to COVID and how Finland has done that. You talked to us about what the Spanish conquistadores called El Dorado. El Dorado, how we integrate health and social care and the different levels of care. And I know Finland has been working hard over the years and has been very courageous now in putting in place these new reforms. And you reminded us of the first commandment of implementation, which we keep forgetting: dialogue, dialogue, and dialogue. Yeah. But as we talk about innovation, one thing we learn, one thing that the Pan-European Commission led by Professor Monti here with us today is the environment of innovation. What we learn a lot from the Observatory and other groups in Finland is that not only innovation within the health system, is the broader societal innovation, the broader efforts of the public and private sectors to get innovation throughout all sectors, which then permeate down into the health sector. So it is indeed a bottom-up, but it's an element of strategy and top-down. Could you say a tiny bit more on that, Lisa Maria?
Yes, thank you. That is a very true observation. So what I was speaking first about the health growth strategy, which is a little bit inappropriate title for the project. It's a joint venture of 3 different ministries, and it actually does reflect the feeling in the society that we need to work together with different sectors. I mean, the health sector is not working or innovating in isolation, but it's very strong cultural pressure, I would say, even from our population, that we should adopt in the health system new approaches to good customer service, if I may say so, that we are already accustomed in other sectors in the society. So you are absolutely correct. It is a very strong cultural background also here. Thank you.
So we all need to learn to be a bit more Finnish then. Thank you very much, Lisa Maria. I'll bring you back in a minute for the final panel discussion. Now, I'd like to welcome Francesca Colombo. Francesca is, as I said earlier, the head of the health division at the OECD, a good partner and colleague with whom we work together, collecting evidence, collecting information to support our member states. And Francesca is going to tell us the very good analysis they've been carrying out about assessing innovations, assessing the responses we have had to the pandemic, and what been the key lessons from that. Francesca, the floor is yours from Paris. Thank you for being here.
Thank you, Joseph. Thank you very much. And indeed, we have a long-standing partnership, I would say partnership in crime, in looking at health systems reform and opportunities. And I would like today to talk and make a few key messages. The first key message is around how the pandemic has accelerated innovation opportunities. And if we look at implements, it's quite clear that a first lessons for implements is just to jump on opportunities. There has been lots of things that happen, and we've highlighted some examples of those reforms that were triggered or accelerated by the pandemic. And clearly, a very important thing is just to take on board when there are opportunities and jump with that. But we'll also highlight requirement for greater investment in resistant health systems and also some specific factors for success of reforms. So as I mentioned, the COVID pandemic has accelerated health system innovations, and I will make just 5 examples. They're by no way exhaustive of everything that we have seen across countries. But starting first with a couple of examples on the health workforce. And why I choose the health workforce is that actually the health workforce, the labor markets in the health sector are very rigid. And that was the case particularly before the pandemic. So systems where the numbers obviously are controlled, often with numerous clauses, where there are strict requirements for practicing. There are very strict definitions of roles and tasks of different professions. What happened with the pandemic is some of those rigidities have been lifted to improve actually the guarantee and improve the care for patients. This is an example here about, for example, what we have seen with pharmacists. Lots of innovative use of pharmacists in different countries, both in terms of facilitating their use for guaranteeing access to care and treatment. Portugal, for example, introduced a free new type of opportunities for pharmacists to renew and repeat prescriptions for chronic conditions, to dispense certain medicines that used to be delivered only in hospital, for example, and to deliver at-home medicine for vulnerable patients. There have been use of pharmacies also in the context of triaging patients and testing, obviously, for COVID-19. And clearly, in a very large number of countries, at least 8 or 9 that we know of, they're being used for vaccination. So that's the very first thing. Workforce innovations, lifting some of the rigidities, like clear definitions or rigid definition about what a pharmacist should or should not do that existed before the health crisis. Similarly, there have been innovations in terms of leveraging the medical reserves, either pre-existing medical reserves that have been set up. France had a health reserve that was set up following the 2007 pandemic crisis, and in the context of the current crisis, particularly in the first wave, lots of those health workers which were either inactive because they were maybe doing a different type of jobs, maybe in some cases they were retired, they were mobilized. So the mobilizations also of medical and nursing students is something that is really innovative and also a flexible way of mobilizing health professionals. And similarly in Belgium, new reserves have been created. So that's my first message. Obviously, there are rigidities. There are a lot of rigidities in health system that existed prior to the pandemics. They've been somehow lifted because of the need to provide access to care in a quick way. And there is an opportunity to maintain them also following the pandemic. So the urgency, in a way, it's a great acceleration and an important lessons for implement. Let me move on to another area which has been highlighted by the previous speakers as well, which has to do more with the digital transformation in health systems, starting with actually mental health, where we've seen that the digitalization, if you want, of health system has created opportunities for delivering of services in a different, more innovative way. And if we see, and this is an example from a non-EU countries, England, on how the balance between face-to-face services and non-face-to-face video or phone delivery or other type of digital solutions has shifted very much as we moved into the different phases of the pandemic in favor of using more innovative, more flexible solution for the patients. So in terms of implement, there is a huge thing here to learn about how these innovations offer in opportunities for a more people-centered, patient-centered health systems, and how, again, certain rigidities that might have existed in the way payment mechanisms were made for online or different modes of providing services can indeed be lifted. Similarly, there's been an acceleration in the use of digital technologies linked to telemedicines, and this graph shows, for example, how the percentage of people who said they did use a medical consultation online or through a telephone type of facilities since the beginning of the pandemic and up to February, March 2021. And we see really very, very large numbers. To look at Spain, Slovenia, Poland, over 60% of respondents said that they used telemedicines. This is all the more extraordinary to think that before the pandemic, those numbers were around 4%. On average across OECD countries, only 4% of services were delivered through telehealth or teleconsultations. And the last example I wanted to give you is around artificial intelligence. Again, lots of accelerations from the pandemic and huge opportunity in many different areas, obviously for drug discovery, using machine learning in different countries to identify molecules that can help us to halt viral replication. Much more responsive way of providing people-centered care in Spain. There have been some automated chatbots in some regions that have been created to facilitate, persons having access to information, then inquire about systems and receive advice. There's been also opportunities to get faster diagnosis and prognosis, for example, by learning from using artificial intelligence tool to read CT scans, and obviously navigating and searching big data to spot infections and target policy in terms of early warning and surveillance. Now, all of these are the good news, but there are obviously some lessons, important lessons for implementations, and here some of the messages also resonate with what we have heard from the previous speakers. The first of all, I think, as I mentioned, is jumping on the opportunities, but it's quite clear that there needs to be some foundations for health systems for successful implementations. And two of them that I want to highlight are obviously the capacity in terms of workforce and the skills, and the opportunities in terms of health data infrastructure and health data governance. So workforce capacities and skills are quite fundamental, and data that we have looked at before the pandemic showed how a very large proportion, some 80% of health professionals, felt that they were either overskilled for the tasks they were doing or underskilled. They didn't have the right skills in terms of communications with the patients, in terms of empathy, in terms of managing difficult decision-making processes, and clearly in the context of the pandemic that has been accelerated. So a clear lesson for implementation is the importance of those more soft type of skills, which are fundamental for health professionals to do their job. But the other important aspects is the investment in strengthening information system and data governance. It was highlighted on the experience of Finland, the importance of real and timely data. We have seen it in the context of the pandemic, and still so few countries are able to mobilize data in real time to support clinical optimizations as well as research and governance of health systems. So clearly an area where implementation is fundamental. But also if you think areas like artificial intelligence, an important key conditions for implementations is the ability to have high quality and representative real world data that can be plugged into artificial intelligence tools to support implementation. So a lot of agenda, opportunities which are huge, but a lot of agenda of things that need to be done for the timely data, for the improved data governance, respectful use of data, but still obviously use of data to support those clinical improvements of optimizations, research and surveillance. Another big learning has to do with the importance of enabling environments. And enabling environments is a very broad context, but it has to do with facilitating an environment for innovations, something that rewards, that lifts barriers that exist, that rewards innovations, but in a way also that does not penalize, obviously while guaranteeing safety of care. And if you think again, the example of artificial intelligence, how much and important it is to have a dialogue also, both at national and international level, which is inclusive and informed about what are the values, what are the institutions which are really needed to ensure trustworthy stewardship of data and artificial intelligence. And the issues of trust, has been mentioned already by the previous speaker, in implementation is fundamental. We have seen it, obviously, in the context of the pandemic. It's very relevant for the digital transformation of health systems, but also equally for ensuring that the communications with patients is managed appropriately. The integrated response is again another important areas. What the pandemic has done is that it has lifted some of the silos that existed, and I think there is an opportunity to build on that for implementation again. That requires moving across sectors, the social care sector, health sector, but also think about the prevention, public health, and the health system. And quite clearly, there is a need to an opportunity to learn from international from international benchmarking. And I make here just a picture of the the country profiles of Slovenia. Again, that's results of successful collaborations with the Observatory and the EC. My last point is about the importance of strategic and sustainable investments, because as much as we need to jump on board on opportunities for innovations, it's quite clear that what the pandemic has highlighted is also the need for investing more in health system. And we have done some back of the envelope, if you want, calculations to see how much will need to be invested to make health system truly more resilient across OECD countries. And we come out with an additional investment of 1.5% of GDP, which in large parts, about 1% of GDP is actually for increasing workforce capacities and skills. And another important part is for improving those foundations, including the data foundations, which are very much highlighted. So to conclude, huge opportunities for implementing innovations, jump on board on these innovations, but you need to have some foundations, skills, workforce, and data being very important, and invest in the reform process, the implementation process, in the way which is inclusive and respects agreed value across the stakeholders and populations. Thank you very much.
Thank you. Thank you very much indeed, Francesca. You reminded us, and very effectively, of the COVID as an accelerator, as the leapfrogging. And the leapfrogging not only on areas that were there were technologies, the telemedicine has been there for ages. But look at the beautiful example you presented in telemedicine, Francesca. It's not just the innovation of telemedicine which was there, but actually the transformation, the implementation, the regulation. We saw within weeks, literally in some of our member states, paying for telemedicine, providing incentives, deregulating and re-regulating so telemedicine could be put in place. With all these obstacles we had over the years, member states managed to do that very quickly. Key fundamental lessons there about integration. I love your point about the soft skills. We forget our soft skills. We're running a bit late, but later I'd like to start with you in the debate on a key area, as you said, us being partners in crime, on benchmarking. How do we use benchmarking? I'll ask our member states as well. How we use benchmarking to support, to implement, to harness that power to make change. So I'll see you in a minute from Paris again. And now I'd like to introduce Mario Nava. Mario is joining us from Brussels. I already said he's the Director General of DG Reform, a new directorate who's working very, very intensively in supporting member states throughout. Remember that range that Nick was telling us about of the process of change, from the evidence side, from the piloting to the actual implementation, technical support. So Mario Nava and his staff are working with several directorates trying to provide, succeeding to provide support in various areas, and health is indeed one of the important ones. Mario, welcome to Ljubljana today from Brussels, I believe.
Good morning, everybody, or good afternoon, dear Josep, and thank you very much. First of all, thank you for the nice drawing of each and every of us. I hope you distribute them at the end, because they bear a resemblance somehow, and at least in my case, they improve, so excellent. Second, let me start, let me start on a light but not uncorrelated note, and then we go to the deepest part. The light but not uncorrelated note regards what the Germans like to say, the most serious of the non-serious thing. The most serious of the non-serious thing is football. And as we, many of us may have followed recently, there was some football going on. What we learned from there, what we learned from the sport is not dissimilar from what we need to learn for health. I mean, sport and health have a very obvious correlation, but also sport and healthcare, in particular when it comes to collaboration, when it comes to team spirit, when it comes to persevering through pain and to setbacks when it comes to being able to never give up and to continue. We saw it beautifully with the victory of a European team, and I think that lesson goes through in other areas. Nick made an excellent presentation of the report, and probably was even too generous to my DG. He said that this is the most important instrument that we have, the one of technical support. I don't know whether it's the most important instrument or not, and actually doesn't matter. What it matters is that it's an important instrument and something that helps. Now we are talking in the implementation session, and great, but something that helps also in invest, collaborate, and new opportunities of which you will be taking, we will be taking later. What do we do here? We do help member states to implement growth enhancing reforms. We listen to the needs of public administration, to stakeholders, to the citizens. We take time to understand their unmet needs. To be clear, when a reforms come from the member states, what it comes at the very beginning is an idea, and it's right like that. And then we take the time to develop the idea together, to create an environment which is ready to make these ideas and new opportunities and innovation to blossom. We do work on demand. We do not work by initiatives. My president likes to say reforms do not come from and by Brussels. Reforms come from member states. So we do work on demand of member states, but what we make is that, as the new wording goes, we make real the reform agenda. So we make sure that the reform agenda can be transformed. And in public health, I think there has been a major change in the attitude of many of us. Public health, for many, is the reason of being public, was mostly a social reason, because not everybody can afford it, and therefore it is correct to make sure that everybody has access to it. In reality, the reasons were much more profound and much deeper. In reality, health is a public good in the purest sense of the word. And you already mentioned Professor Monti and his extremely crisp analysis and his call for action to national governments and the global community. He calls for 3 actions. Action number 2 is step up investment and reforms in health and social care systems. And I think the pandemic has shown to us that health is truly a public good. It's not important, it's not enough that someone is healthy. We need basically everybody to be healthy. And the discussions we are seeing in these days on the coverage that comes from the vaccination, I think, are a very good reminder of that. So the Pan-European Commission of the WHO, chaired by Professor Monti, made that call, which we think is very legitimate, and we really want to take it seriously and to help member states. I will be giving you a few examples of where we help member states, and I will be covering areas that, for example, Francesca already has been covering, or others. So the first area clearly is Slovenia. We are there, we are in Ljubljana. You lucky are in Ljubljana. We are under huge rain here in Brussels. Only a month ago, the government adopted a long-awaited bill on long-term care, and we have made a sort of, the government has made a sort of institutional and community-based form of long-term care to be developed. So you, Josep, you are saying the development of these means the development not only of the scientific aspect, but also of the regulation that goes with that. And I think the title of this conference is Innovative Solution for Resilient Health System. Well, the innovation starts from the lab, but does not stop at the lab. The innovation goes beyond the lab and gets to, for example, regulation, for example, organization, for example, cooperation, and all of that. A few weeks ago, we did the design of the Genome DE, which is we reached a major milestone, and we presented with the German Ministry of Health, which is a way to bring genomic into health. That is pure innovation that will help fighting cancer and rare diseases. And that, of course, brings about a completely new legal and ethical framework, a completely new organization of data infrastructures, of way to reimburse, which go well beyond the issue of medicines. But for example, in Slovakia, a few weeks ago, we are working with the Ministry of Health, and a few weeks ago we organized an hackathon. An hackathon is a sort of marathon of hackers, of great people able to do coding, in order to build and develop a new software program for healthcare. But this new software program for healthcare, of course, needed the help of the artificial intelligence, of the data analytics, and of all the other experts in the area. But clearly, this time we have not only the technical support, which is great, and which has been reinforced massively by the current MFF, the current multi-annual financial framework, but we do have also the recovery and resilience facility. The Marshallian moment has been called probably the biggest type of instrument. Facility means instrument, the biggest type of instrument that we have in order to do reform and investment. And in doing that, you were very right in your, Josep, in your comment to Francesca. In doing that, what we are trying to do is really to accelerate things that somehow were there and existed, but because there were less needs, they were not so developed. I mean, telemedicine infrastructure is one of those, and actually we are working on a project in Slovenia and in Spain, but also digital transformation of the health system is a project where we are working in Belgium, in Estonia, in Croatia, in Greece, in Czech Republic. We are looking, for example, at multidisciplinary care services in Austria, in Spain, in Portugal. What is true is that in order to do this, and as I think the example of the hackathon shows it clearly, investment in people, in services, in network, but in education is absolutely paramount and crucial for the healthcare sector. I mean, we need to form today the doctors of tomorrow. Ability, of course, is crucial. There is a famous saying that it says that skills is the art of turning limitation into virtues, and that is great. That is excellent that we have it in the human ability, but definitely we need lots of education. And it's exactly for that, and I will be concluding here, that in our rolling out of the TSI for next year, for 2022, we have put the emphasis on some flagships, and one is truly to do with the combination of the health issues, the digital issues, and the education issues. So we have set up a flagship for the digital skills for the digital transformation of healthcare systems, and we really attach lots of hopes, or maybe even more trust, that can really help member states that they so wish in developing a new healthcare system. I'll stop here and very happy to take questions in the debate. Thank you.
Thank you very much indeed, Mario. That was excellent. I am sure after this presentation you'll have many more requests for support and work, and I thought it was brilliant the way that you were echoing this idea, echoing your own philosophy, presenting your own philosophy to go throughout the whole process of change. And where are, as it were, the points, the real key elements, key instruments, key spaces where we can make bottlenecks. I was looking for the word bottlenecks. It's precisely working on these bottlenecks. And you talked about skills and hackathon actually, and indeed, hackathons. We have one every year actually in the Health Forum Gastein. We have all these skills with these youth, with these people that we need to bring on board. I wonder whether I could encourage, not being anybody as I'm nobody, DG Reform to support more of this development of human resources, as I believe you do in part of your programs in member states. But I'll bring all of you back now to the studio, and we're going to have a debate together as to how that sounds together, both from the member states' perspective as well as from the servants of the people, the OECD and the DG Reform. So if I can have the two capitals joining us here, Paris and Helsinki, and as they join us on a screen, together with Mario, I'd like to introduce Nicole Maurer, who's now in the studio with us, who together with Dimi Pantelli have been monitoring the chat. What's going on, Nicole, in the chat? What are people telling us? I hope they like it, really. I hope they like it, because this is beautiful.
I think the chat is still warming up, but we're starting to get some really interesting questions. So first of all, we're being reminded of how important it is to rebuild health systems now that we've had this crisis, that COVID has happened, and also people are pointing towards various stakeholders who have been carrying out work and pointing out to innovative solutions that have been deployed by the different EU states, and we've also heard them already today. But we're also reminded of the importance of not becoming complacent too early in the process of implementation, because it's very important that after we implement, we also carry on evaluating, making sure that new data is being implemented, and that so the evidence is really taken to make implementation even stronger. This also links to the importance of avoiding wasteful spending, so it is crucial that we monitor the way that we spend and that we use innovative solutions for that as well. So overall, people are wondering, how can we push beyond just implementing, and how can we reach these long-term sustainable objectives? And also to the EU states, participants are asking, if you had a wish list, what would you ask from EU support to recover from COVID and to do better in the future?
Perfect. Thank you very much indeed. I like that. Evaluation, 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 and waste. We should be cautious. We should be cautious as we have all these new funds coming on board, that we're using those funds effectively. We're using these funds efficiently. So good emphasis on evaluation that actually Lisa Maria made very clear in her presentation. Actually, she highlighted the element of evaluation very much. Why don't we start, therefore, with this question that comes from our chat box. Vesna, Lisa Maria. Wish list. Wish list. What else would you like the EU to support you with, enable you?
I very much liked when Mr. Nava said that they are acting on the demand. I think there will be a lot of demand, Mario, because I think COVID has shown us that we have to reform much faster than we did before. And to reform faster, we here believe that it takes cooperation, it takes good practice exchange. So we would want to have support in this regard. If you look at which topics would be really important, they were already mentioned. Digital health is very important, and we could see a big progress also in my country in how we can digitalize if it's necessary. Before it took ages, but during the COVID things really moved fast, and now patients can look at their digital records and so on, so it's much better than it was before. But there is also another area such as mental health. We also have seen how mental health is really important and how important it is to have services available to where people live, to support people, not only when they are seriously mentally ill, but also when they have problems so that they don't get mentally ill. And we have to assure this network of services actually close to people. And this is also something that I think we would need to learn from each other, to work together to find appropriate solutions here. And the third thing that, of course, has also been very obvious during COVID is the long-term care, the facilities there. my minister was now listening to Lisa Maria, and he got some new ideas, you know, when he saw how they merge social services with health services. It's a little bit harder for us. We have 2 ministries in place to deal with this, but it was very inspiring, as he told me just minutes before. You know, so there are many areas that we could work together, and we could work together in different ways.
Perfect, perfect. Real convergence of priorities there. Mario, I hope you're taking notes here, and you're going to organize already a study trip of exchange between Slovenia and Finland on the area of integrating health and social care. I'll come back to you in a minute, Mario, but I want to go to Lisa Maria first. Lisa Maria, what would be your wish list? You already made a clear emphasis on the data space, on the health data space, in which indeed Finland is excelling already, and how you can collaborate and across countries. You want to add something else there, Lisa Maria?
Thank you, Josep. I think that's really one of the key projects or key initiatives that Finland is really appreciating, and also, you know, we cooperate with many other member states and institutions and so on to make this really happen, because it sounds easy, but it is by no means an easy and simple task to fulfill. It will take years before we really reach our goals. But you are absolutely right that the COVID crisis has been a strong booster and facilitating factor, that many things that we thought are not possible to the health sector actually overnight became possible to pursue. But I think that the COVID-19 crisis is a global crisis, and it has, you know, brought us more together as a global community, but it also has brought into attention the competition that the EU has globally. And I think that one of the issues that we all look forward to is that the EU could support the innovation value chain, so that there would not be that much competition between member states, but more cooperation when we look for solutions for future health threats and challenges. Thank you.
Perfect. Competition and collaboration. Let me now try a couple of difficult questions. I'll go to Francesca for a difficult question, and from Mario. Francesca, as partners in crime, and as you were saying earlier, we are about to launch the 3rd generation together, under the leadership, under the support, working very closely with the European Commission, DG Santé, the country health profiles. You will recall the first time round that we were very worried that member states would say we're benchmarking them. What is the power? And we're actually not benchmarking them. We are comparing. We are learning from each other. How can we use this power of benchmarking more effectively within a European Union and indeed the wider Europe, European region of WHO, where there's so much richness, there's so much to compare and learn from each other. How do we use that for better implementation?
Yeah, sure. And I mean, the issue of benchmarking, it's a tool. Benchmarking is a tool. It's a tool for implementing change, for supporting a change process, which obviously is geared towards improving performance. And there are different things that you can do with benchmarking. You know, one way you can do is really looking at indicators, quantitative indicators, and the country health profiles. Even if we're not, you know, naming and shaming, we do see how a country, you know, does in relation to others within the EU Commission, in the EU countries. And I think that ability to show how you compare, it's a very, very powerful tool for looking and understanding where do I want to improve myself. But it's not something that is imposed on any country. It's just a way to facilitating improved performance and transparency in performance that helps, you know, everybody in their reform process also thinking, these are the areas which I want to focus on. There is then the other aspects which was highlighted also by the Commissioner when talking about best practices and implementation of best practices. And I think there is a lot through that benchmarking, which is a particular importance in highlighting, you know, how countries are doing well in some areas, and this offers a huge opportunity for learning. And again, through the state of health in the EU, this process and other, you know, projects that we're working also with the Commission on It's this particular value of showcasing some of the useful practices, the best practices, and facilitating the implementation in other contexts, understanding what are the conditions that may need to replicate exactly as they were, or the conditions that might need to change to be adapted to more local situations. Lastly, I think, with the benchmarking is something that needs to continuously improve. Over the years, obviously, we have, the OECD and with the states in health in the EU process been working on continuously improving what you measure as well. And I must say, and that's linked also to the issues of the digital transformation of the health system, that there is an awful lot that we still need to measure better. You highlighted before the issue of integrated care. We lack really good measures of truly integrated care, ability to see what happens to patients that might circle back between the long-term care system, the hospital care, the primary care, and really understand what goes well and goes less well in that process of moving across the system. That's the situation of countries, of patients which are complex patients. So
thanks very much.
Interesting, yeah.
No, and indeed, Francesca, we learned that member states are happy to be benchmarked. They're happy to learn from each other. They're happy to be much more visible out there and learn from success and failures. Which leads me to Mario very shortly. Sorry, I ran out of time today. Mario, difficult question for you as announced already. Subsidiarity. Some member states are saying, no, we don't want Mario to come to our country and support us because they'll set up our priorities. My impression with those countries we work with is they don't feel that way. What would you say to those countries, Mario?
Well, I mean, for the record, we get requests from all the 27 countries. So it's an imaginary country you're talking about that doesn't want us to do. So no, we have requests from all the 27. Last year we had 706 requests from 27 countries. We can support only 200. But I think you have an important point, which is the one that we don't come first. So we wait exactly because of what I said, the ownership of the reform. So we wait for the member states to mature, to have a developed idea of what type of reform they want to do. And then they call us. And when they call us, it's not a one-time call. I mean, then it starts a process of several months, sometimes years, of very good cooperation together, and we see how to do. You highlighted the point of member states helping one another. I mean, is incredible. Now, if you think ages and ages ago, there was a famous single market case of country A that didn't want the dentist of country B because said that the quality of water is different between A and B. I mean, all these things are gone. I mean, now we are in a completely different world, and we can really implement a lot of help among countries. Thank you.
Perfect. Thank you very much. Let me get close to the screen because now we have this surprise. We have these cartoons or these caricatures with the key messages. I'll use those to thank my colleagues today for the excellent presentation and contributions. So we have first Vesna, Kerstin, Petrič saying, in my country, oops, we're very proud of our health system. Leadership is not only on the top. Very well captured, our cartoonist today. Leadership is not only on the top. Although, Vesna, you're now on the top. I've seen you as well in the bottom. I've seen you, not in the bottom, but in many parts of the health system, pushing and leading everywhere. And that's the lesson, one of the key lessons we learn from you. Leadership is throughout. Bringing people together is what makes a difference. Next one, please, which I think I control, is Lisa Maria Voipio, Pulki. There has been progress, but it could have been faster. I like that in Nordic countries and southern countries as well, Vesna. It's always this self-criticism, this assessment, this evaluation. We could have done better. Medical innovations need to be supported by organizational innovation. Very much. Well captured, exactly. Organizational innovation, not just the technology, the medical technology, but organizational innovation. Thank you very much indeed. Now we have, I believe, Francesca Colombo. Rigid definition of what the pharmacists should or shouldn't do have been lifted. Indeed, Francesca, indeed. Pharmacies are not there to sell drugs only. They are there as an important skill mix to make a difference, to support, to better treatment, to better adherence, to right combination of drugs. Medical professionals, though they were thought they were overskilled or underskilled during the pandemic. Core element. You guys capture it very, very well. It's exactly the skill mix. The skill mix was a core message from you, Francesca, from which I'm very grateful you put on the table, and this wonderful analysis that the OECD did. The skill mix has been one of the main lessons we learned on the COVID pandemic and how to fast track this change in skill mix. And last but not least, we have Mario Nava. Mario Nava captured you very well there, Mario, with your smart smile. The most serious of the non-serious things is football. Hey, there we are. I didn't mean that one. I didn't see that one coming. Sport and healthcare have a great correlation. Health is a public good in its pure sense. Let me highlight that. In our conversation, Mario, we talk actually with the other Mario that you said was your role model, Mario Monti, and how Mario Monti is in the call for action putting this idea of externality. We learn it the hard way, the externalities of health. Beautiful way to summarize it. And to all of you, thank you very much for being here. My deepest apologies. I've been a lousy moderator because I took more time than what needed, but I think you'll all agree with me that these professionals today, these speakers were absolutely brilliant, and they deserve a virtual applause of some sort or other. Thank you very much. I'll ask Igor now to close us for the remaining.
Thank you very much, Mr. Figueras. No, you did great. I mean, we're in time. Because my next task is actually to announce a lunch break until 3 o'clock local time, which is in about 50 minutes. I wish you dober tek in Slovenian, which literally means have a good run. Well, it's the Slovenian way of saying bon appetit, and as you may know, Slovenians are a sports-obsessed nation, so even during lunch they have to do something with sport. But because Mr. Figueras said that everybody should copy Finland, I would also say this in Finnish, hyvää ruokahalua. So please come back here at 3 p.m. local time for the second part of the conference. Dobar tek. So, ladies and gentlemen, welcome again at the high-level conference of the Slovenian Presidency of the Council of European Union, organized by the Ministry of Health of the Republic of Slovenia, in which we discuss the implementation of innovative solutions for resilient health systems. We are at Ljubljana Castle above the Slovenian capital, where some of the participants are here in our studio and some are online. Our next panel will be moderated from an online location in the United Kingdom. I'm very pleased to announce again Mr. Nicholas Fahy, Expert Advisor of Innovation and Implementation. He's Senior Researcher at the Nuffield Department from Primary Care Health Science, University of Oxford, who will host a high-level panel on mobilizing finance for innovative transformation. So, Mr. Fahy, thank you very much again for your cooperation, and the floor is all yours.
Thank you, Igor, and welcome everybody to this session on Invest, Mobilizing Financing for Innovative Transformations. Igor, you said before we broke for lunch that in Slovenia everybody is very active and very sports interested, and as one of the people who is not there, I am now thoroughly jealous as a result of the beautiful footage that you showed us over lunchtime, and determined to be active and get myself actively to Slovenia another time. But for today, I have to moderate this session remotely, and I'm very grateful to the support of all of your colleagues in the Castle who are arranging all the audiovisual support to make sure that this happens so smoothly and so professionally. We have three very distinguished speakers for this session who represent a range of national experiences, and also the contribution of one of the key European institutions, which I referred to in the earlier presentation, the European Investment Bank. But we'll come to the European Investment Bank later on. First of all, I would like to turn to Austria, to Dr. Clemens Auer, who is Special Envoy for Health in the Ministry of Health in Austria. Dr. Auer has many different responsibilities and has had many very specific responsibilities during the COVID pandemic, I know, and we're especially grateful to him for making time to come and speak in this session today. And we're very keen to hear about the Austrian experience with primary care reform. Clemens, over to you.
Thank you, Nick, for your kind introduction. Dear Minister, dear Regional Director Hans, by the way, let me introduce this thing on a personal note. You know, when I was driving yesterday evening, early evening from Vienna to Ljubljana, I crossed the border at Spielberg, and I remembered very vividly what happened 30 years ago in June and July, this so-called Slovenian war. And, you know, then driving through Slovenia, what a beautiful country this has become, you know, prosperous and beautiful. Really, it's a delight. I also do support strongly the intention of this presidency conference, learning from each other, closing the gap between theory and of change and implementing change. And my whole professional career, I always conceived myself as a change manager, closing this gap between theory and implementation many times and many incidences. And the organizers invited me to speak on the investment on primary healthcare, because that is a very important topic also for the Austrian health system. And where do I come from when I talk about primary healthcare? I would say that the state of play of the primary healthcare in Austria is probably the biggest challenge, if not even threat, for the stability of the Austrian healthcare system. And I don't say that the thousands of healthcare physicians, primary healthcare physicians, doing a bad job. No, I'm not saying that. But what I mean is the structure, the delivery structure, the organizational framework. Just one number, by 2025, more than 50% of the primary healthcare physicians in Austria will have reached the age of 65. And 5 years later, in 2030, 66%, 2/3 of the current primary healthcare physicians will have reached the retirement age. Can you imagine what that means for access to these primary healthcare services? Can you imagine what that does to the financing structure of the overall system? I just talked to the minister, you know, patients should only come to a hospital if it's really necessary, but not if they need primary health care. So then I also am confronted when I speak about primary health care in Austria with a very opaque self-governing system, you know. The social health insurances in Austria are self-governing, the chambers of doctors are self-governing, and to be frank and honest, these organizations don't have the people in mind, they have their own interest in mind. And, you know, when it comes to the chambers of doctors, I'm very critical here. You know, they're old men sitting and protecting their economic interest. And their economic interest, and I said already something about the age structure, is to resell or sell their practice and not to change it into a modern infrastructure which can deliver good services. And then the other point I would like to make is I'm also coming from experience 20 or 15 years of neoliberal budget policies in government. So healthcare expenditures were always conceived as a dangerous cost item and not as an investment. So I had to cut out of the Austrian healthcare system many billions of euros over the year, so not much room for investment. But anyway, we were able to start a primary healthcare reform, and first step was 2014, by the way, with the help of some friends in this room here, with Josep Figueras and the Observatory. We came up with a very sound political consensus paper on the need of change of primary healthcare reform. And Parliament passed a huge Reform Act 2017 with a legal frame of new infrastructure frameworks, collaboration, interdisciplinary collaboration, etc., etc. But then also, we also had to experience the imponderabilities of democratic government, because then we had all of a sudden a populist health minister. She only had interest in reforming social health insurances, and that slowed down the process. But let me talk about the investment, because this is what it is all about. We had 3 different tools of investments going on in this change process. The first was that I always wanted to have a toolbox which enables the implementation for the stakeholders, not so much for me or for the ministry, but for the medical doctors or for the nurses who are doing this primary healthcare infrastructure and facilities. So we created a whole toolbox for legal contracts, employment contracts, business plans. And you find these instruments on the European Commission and Austrian homepage still, because they were financed with funding from the BECS and Structural Reform Support Program, SRSP. There was not much money, several €100,000, but it was very, very necessary and very, very helpful to develop this toolbox to make it easy, because I didn't want the medical doctors to spend lawyers' fees and tax advisors' fees when it comes to create a business plan or do all the legal work to start a business, a primary healthcare business. The second big step, and that was a very interesting experience, was that we managed to have a loan program established by the European Investment Bank, 300 million loan framework. That was very challenging. It was not so much challenging that we got it together, but the challenge was to make primary health care all of a sudden bankable. That's a very important thing. The European Investment Bank friends, they thought in investing into large infrastructure, in a hospital complex. The city of Vienna had one of the big hospitals, several €100 million. All of a sudden, we are speaking about small businesses. A primary healthcare facility is a small business. So it took us a while to figure out the shared language to understand each other, but still we ended up with this 300 million loan package, which is in times of low interest rates not the biggest runner, but still it is a help for young medical doctors to start their business, so to say. And the third element now is that we put also primary healthcare reform and the establishment of new primary healthcare facilities into the recovery and resilience facility. There we have managed, as Austrian internally, grants of about 100 million euros just for the support of primary healthcare, for the establishment of primary healthcare units and infrastructure, because this is very important. It's not about the running costs. The running costs can be covered by the reimbursement and the fees these institutions can earn, but it is about the investment, the initial investment. Let me finish. What is needed, friends? What is needed? After all this experience, for many years, I think the European Commission has to support us in the member states to figure out how these different instruments work. So I'm calling for a really feasible, workable technical support instrument, because we do have all these many instruments, and Nick, you showed it in your presentation. They're all there. They're all there. But very, very, very few people know how they work, how you get to them. So we do need a toolbox. So I'm really calling on to make life easier for the ministers of health to find out about these financing instruments available on the European level. And I would like to finish and say, also in this financing discussion, we need less theory and more mechanisms for implementation. Thank you very much.
Thank you very much, Clemens. Thank you very much indeed. Please stay where you are a second, because I want to ask you one additional follow-up question, because you call for this a sort of a single technical support instrument, somewhere to bring together these different instruments, which, as you put it, are all there, but they're not well known. So how did you cope? How did you manage to combine all of these different elements that you so successfully put together in Austria, and what was that like actually?
By total accident, you know, because this support instrument, the first one I mentioned, I learned, you know, during one of my Brussels trips, I learned about it, and then I said, okay, let's do it, you know, and then I went there and saw the director who was responsible, a wonderful lady, and you know, but she was surprised that I'm coming there from a Ministry of Health, because this instrument was not geared toward healthcare, or especially primary healthcare. So it took a while to talk, you know, and then talk them into, and I think it was one of the favorite, actually one of the favorite projects they financed. And with the European Investment Bank, it was very similar. You know, I stumbled upon a workshop in Brussels, and they told there that they're investing in health. And I said, okay, but then I learned they're investing in large entities, in hospitals. And I said, oh, I don't need hospital investment. I do need investment in primary healthcare. So I called on one of the Austrian directors there and said, you know, and he said, Clemens, you are the first one who is calling me. Ireland and you are the only ones who are interested in getting EIB money for primary healthcare. I said, okay, then do a better job and promote it, you know. And the third element with this recovery and resilience facility, that was more an intergovernmental battle in Austria, you know, to get 100 million out of the whole cake reserved for primary healthcare. But we also managed to do that.
Thank you, Clemens. That's really helpful. Please feel free to escape now and take your seat. But I think that really illustrates like the importance at the moment of just personal networks and almost accidental relations, and whether or not we can do better than that in the future. We will hear from the European Investment Bank in a little while, but first I would like to turn to Dr. Dita Protopopova, who is Secretary of the Governmental Council on Mental Health in the Ministry of Health in the Czech Republic. Dr. Protopopova, you have the floor.
Dear Ministers, Commissioners, thank you very much for inviting me for this conference, and I would like to tell you something about our experience from the mental health reform in Czech Republic. I have a presentation, if we can share it. I don't know if it's already on. Do you see it?
Yep, we see your presentation.
Great, I see it. All right. So this is Czech Republic, just for the information. And we needed the mental health care reform because our system was many years based on institutions and was suffering by underfunding, lack of coordination, stigma, a great stigma of mental health. And as you know about the Czech beer, we also have high alcohol consumption and other things. So we decided we really need a big change, not just some small adjustments, and we wanted to focus as a first thing on the deinstitutionalization as the priority. And that is because we really suffer from this problem. We have a big institutions that can have up to 1,000 patients, and some of them can be there 20 years. So this was something we set as a first step in the reform. So we wrote a strategy in 2013, and then the negotiation about the support from European Union started, and we really got the support which was essential for the reform, and we started the projects, the real implementation in 2017. We had some specific targets, what we want to achieve, what we want to do. The first was to have a new service we didn't have before in our country, and that means some multidisciplinary teams that are mobile, go to the homes of the patients. They are for severe mentally ill patients, and they are social and healthcare teams. And then also the transformation of psychiatric hospitals, where we aimed for and achieved to put down 15% of long-term beds, and to do also other community services besides the mental health centers, because our community system of the services was really like scarce. And also we wanted to enhance the quality of care, and I mean the quality focused on human rights, because this is something that is really vital for service users and also, I think, for the whole society. And also we wanted to target stigma. And so we had 8 projects that were cooperating together and were like covering all the field, and they are now going to be finished, as you see. And what we did a lot of new things. We established these new services. We have 30 these mental health centers. We also had to change quite a lot of financing mechanisms in our mental health, because, for example, the huge hospitals were paid by the bed occupancy, so they couldn't lower the beds because they would bankrupt. So we found another mechanisms, and also what was very difficult was to combine the healthcare and social services together, because we also have 2 ministries, we have 2 budgets, each is different by the process of payments, and also 2 legislation. So we also have to adjust legislation and to put all this together. And I think the hardest thing and the thing we needed to do was to set up a new mindset about mental health, and that needed really intense collaboration, learning not only nationally but internationally. So we traveled a lot and worked with WHO very closely. We used funding from EU, from European social funds. It was for funding the people that were working into the reform. There were about 300 people through the whole country, into hospitals, into regions, to like get the whole process going. And then we had European regional and developmental funds for the investment into the buildings, into the new facilities. We also used Norwegian funds to cover also for other target groups than severe mentally ill patients, for children, elderly. And we also use some financial support from WHO for the strategic planning, because we also did a strategy for Alzheimer's disease and for suicidal prevention. So this was also crucial. And what next? We just started. This was just the beginning, and we need to go on with the reform. So we created a national mental health action plan, which was approved by the government, and which takes into the play also other ministries and other stakeholders, because we also need the Ministry of Schooling, we need to do prevention at schools, we need the Ministry of Justice because we need to change the forensic care, and so on. So this mental health action plan is broader, not just focused on the institutions. And we also established a governmental council for mental health. That is the council that is led by Prime Minister, and all the relevant ministers sit here, and other stakeholders, including service users. And this governmental council coordinates all the things and the implementation of the national action plan. And all this work, all these things we did showed really, really like important through the pandemic, because we could rapidly use all the financial and personal resources we had under the governmental council, and like we did a lot of things through the pandemic for the mental health, like the Central Psychological Helpline, psychological support program for the general population, mental health awareness campaign, and we did plans for establishing a much bigger network of crisis care centers. And also the things that we established through the reform, like the mental health centers, proved very important in the pandemic, because the outpatient care, the access to it was limited through the lockdown, and these centers worked really good and supplied the important care. And I think now the conference should be about how to do it better. So I want to talk about what we learned in the process. And we learned that to coordinate the financial resources is really essential. Because, for example, we did have a social fund, and to support innovation, thinking about new things, establishing a financing mechanism, and we did have investment money. But so when we wanted to do the more acute care, more like acute hospitals, we did have money for it, for investment, but we still didn't have the motivational financial mechanisms. So very few stakeholders use this money to invest, because they weren't sure that the care will be paid for. So for the next phase, we are planning to much better think about how to coordinate all the resources. Also, what we found out, that the process is very lengthy, and change of mind takes a lot of work and perseverance, so we can't give up and go on. And in this process, we need to establish really clear milestones to boost the motivation to get burnout. And the matter of human rights is like the key thing in the reform, because this should be the quality of care should be based on the compliance with the human rights. And I think the most important thing we learned was that it's everything about people, because we need everybody involved. So we need to really talk with everybody and listen to their needs, and try to find what we have common, and how we can target this, and not only nationally, internationally. And I think we weren't really prepared for that, for such negotiations from the beginning. So this is what we learned, and we are now doing much better. And this is everything for me. Thank you.
Thank you very much indeed, Dita. Please stay where you are, because I wanted to follow up on a couple of questions there, if I may. Thank you so much for that presentation. We so often talk about the importance of addressing mental health challenges and services within health systems. We know that it doesn't always receive the attention it should, and this is just an excellent example of a really sustained strategy to try and address that within the Czech Republic, and it's very helpful to have had your presentation on that today, which I'm sure will inspire other people. Can I ask though, because you said it took persistence, and when you were describing the overall process, you said the strategy was developed in 2013, and then there was negotiation, and then the actual implementation started in 2017. So what was the 4 years? Was that aligning people within the Czech Republic? Was that getting the instruments from the EU? What took that kind of time between the initial strategy and the putting it in place?
I think it was both, but I see that more was on our side, because there was no political will to do it. So I think that the first years was thinking how not to do it and use the money, you know, so how to find the ways how to use the money easily, make some small adjustments, but not go into the huge change, because everybody was aware that that will be really, really hard work. So we were pressing. It was from downstairs, you know, from the NGOs, from Psychiatric Association that were really pushing, and even Psychiatric Association wrote the projects, not the Ministry of Health. The Ministry of Health just used them, you know, and not to harm Ministry of Health, we paid for it then to the association, but we didn't do it, you know. So it was really, there was a huge resistance from the system to change. And then now when everybody realized that we are going into it, still the resistance is quite big, so it really needs perseverance.
Well, congratulations. I think that resistance from within the system is something that isn't, let's just say, I think you will find some other people in the conference who are familiar with that sensation, but I think you encountered quite a strong version of it. I'm really reminded of what Vesna, Kerstin, Petrič said before about leadership is not just top down. So it sounds as though in this instance, the leadership in some ways was bottom up. Is that fair?
Yeah. Yeah, I feel that without the huge will of NGOs and all the stakeholders downstairs, it wouldn't be possible to do that.
Thank you very much. And the other thing I just really was struck by in what you said was we focused very much on EU instruments, and we did that in our policy brief because that was the starting point of what we were looking at. But you also mentioned these other instruments, so the World Health Organization and the Norwegian funds. How was it a challenge to link in those instruments with the EU funding? How did you link all of this up at the national level between these different organizations?
Well, we used to collaborate with WHO on many things, so this was just something that they review all our strategic documents, and this was automatic that when they have this financial mechanism, they offered to support the strategic thinking. But the Norwegian funds, the thing is that there is not too much money, so we use it like it add-on if we needed to, you know, to cover some things that weren't really in our plan, but we found out that they are important, so we put it into this program, and they are right now for the next period. We have in Norwegian funds the dementia care and the child care, because we know that until we will get any more money from European Union, there will be some time, and we need to care for these groups like right now. So I think that it's good. It wasn't as such problems for us because it wasn't some mainstream funding.
That's perfect. Thank you very much. And it illustrates the importance of having these additional flexible tools, and also, which I'm sure Dr. Kluge will be nodding while he sat there, the technical support of the WHO as well, and you know, all these different things which are available. Dr. Protopova, thank you very much indeed.
Thank you.
And we've heard a lot about the European Investment Bank, and I'm very grateful that we're able to hear from the European Investment Bank. I think, like me, someone who has not been able to have the pleasure of traveling to Ljubljana, but is in many ways equally delightful surroundings of the Grand Duchy. So it's my pleasure to hand over to Felicitas Riedel from the European Investment Bank, who is head of the Life Sciences Division. Ms. Riedel, you have the floor.
Yes, hello, as well, a very warm welcome from my side. I hope you are all able to see my presentation. So what I'm trying to do is to give you a brief overview what we as EIB are doing, in particular with regards to the health sector. In order to start, for those of you not familiar with the EIB, this slide provides you an overview. So we have been established in 1958, and what you need to remember is that we are the EU bank. We are owned by the European member states, and we are in essence supporting projects which provide value add for European citizens. As I think there's no doubt that health and access to innovation is something that is considered being important. That's also the area that I'm particularly responsible for. What distinguishes us from other commercial banks is that we not only are working with our classical bankers, but we also have an entire technical department. Myself, I'm heading the Life Science and Health Division, and we are a team of 18 experts that is composed of medical doctors, health economists, PhDs, and engineers, in particular hospital engineers. EIB is accessing its funds from the capital markets, and due to the fact that we are AAA rated, we are able to obtain the funding at promising interest rates. In order to link this to the conference, I listed here some of the issues that we are facing with having been investing into the health space actually for over 20 years. So what we have noticed, and I think it was already briefly touched upon by the previous speakers, is that there are several countries that still struggle from a legacy of either oversized or physically deteriorated healthcare infrastructure that was particularly evident now also during the pandemic crisis. Also, I think what has become evident, in particular also in the last year, is that public health information systems are not actually communicating with each other. There's a fragmented data collection and also a lack of a consistent collection of data. There are some exceptions that do this particularly well, but overall digitalization is clearly an area that needs to be improved. What also makes, from a financing perspective, investments into healthcare or healthcare facilities often a challenge is that you have different public entities that are responsible or owning these type of facilities. So who are your concrete counterparts to talk to, or who would be the actual borrowers of the money? What is also important in order to support sustainable healthcare infrastructure is that they are linked to strategic development plans where you have a clear needs assessment and you actually know what you're going to need when in the future and where it's best located. So what was also already briefly coming out of the previous presentation is that it's of course important to also have access to long-term capital, and this is something that we as EIB also are able to provide as we are the long-term borrower. Another topic which is maybe less linked to financing is the fact that there is quite a divide or a movement of healthcare staff that is being very well educated, but leaving to countries that offer a better pay, and therefore there's an overall shortage of highly qualified staff in the health sector. To put it in a perspective, so I think EIB is quite an important investor in the health and life science sector. Exceptionally, as you can see in 2020, we have done lending volumes of over 5 billion euros, but on average, we do invest about 3 billion euros per year in the sector, which is quite significant. And I also would like to make a point clear, as you can see in this slide. So what we do support is more than pure infrastructure. Of course, healthcare infrastructure is very important, but there we do actually support primary healthcare, which we fully agree is of essence for a healthy health system, but we also go into tertiary or secondary healthcare infrastructure. We also look into innovative way of healthcare provision. So we are very well aware of that the traditional ways of patient care are also being questioned, and that there are more modern ways of also linking, for example, the advantages or advances in e-health, telemedicine with a classical healthcare infrastructure. We also do support the innovative, intangible assets that are also necessary. So you can have a fantastic infrastructure, but if you don't have the proper equipment or the necessary drugs in place, this is also not leading very far in terms of having a healthy population. So we do support the development of novel drugs, therapeutics, diagnostics, medical devices, but equally important as well, vaccines as prevention. And I think the last point I want to draw your attention to is that EIB is also providing advisory services, as I briefly touched upon before. It is very important that health projects are embedded in a sound overall strategy and plan, and we do support the setup of feasibility studies and to come up with proper concepts that can then be also financed to the implementation. And the development of the 3 regional hospitals in Romania, I think, is a very known example where also the EIB advisory team with the hub and the commission was the basis of preparing the projects that have now actually also received financing and are being implemented as we speak. What I also wanted to conclude upon is that, of course, I think COVID-19 has been not only a tragedy and a very significant amount of time that we all spent last year to try to cater for this crisis. It has also demonstrated the need and the importance of health globally. And what we as EIB tried is to look into all the various areas, and therefore what we did, we provided support to have vaccines available. So I'm very proud to say that we are amongst the first ones to have supported BioNTech, but we also looked into supporting various treatments, options ranging from small molecule monoclonal antibodies to cell therapeutics and diagnostics. But we also have supported the healthcare provision, and here we supported the availability of ventilation system, protective equipment, and ICU beds in the various countries, so to make financing immediately available in order to cater for these ad hoc needs. All of this is important to also do with partners. So EIB has very close collaborations, not only with the European Commission, but we also collaborate with the WHO and Bill and Melinda Gates Foundation. And this, of course, makes our investments much more meaningful and also ensures that the proper impact is being achieved. I think this is just, again, an overview of the type of interventions that we do support, and I think this I have already touched upon. I think what I want to leave you with, or to be left for the discussion going forward, I think that the crisis has shown that the healthcare systems have been put under tremendous strain, and that this pandemic is not over yet, and still additional investments are needed. Also, I think it has clearly shown that overall, also in Europe, we have a deteriorated health care infrastructure that also needs to be seeing additional investments in order to be better prepared for any future emergencies that come across. One thing we all need to be clear is that this wasn't the last pandemic, that other pandemics will appear, but what we all need to do together and join forces is to ensure that we indeed take the lessons learned from this pandemic seriously and are better prepared going forward, and EIB stands ready to support this process. And I think with that, I go back and be ready to answer your questions.
Thank you very much indeed, Felicitas. That was very helpful, and you have that was rather inspiring, actually. I know you thoroughly dispelled the impression of a bank that just builds concrete hospitals. You know, there is a very big range of activities that you're financing there, I think, as so often with these EU tools, I come back to what Clement said a few minutes ago, that the tools are all there, but we don't necessarily know them, and we don't know how to use them. And we see with what you're talking about that you have a lot of tools there, but indeed I would have had the same assumption as Clemens, which is that for some of the soft changes, the more sort of the people changes, the organizational, the skills, the human dimension of health system transformation, that would be a hard thing to get support for from an institution like the EIB. What advice would you give to people in health systems who were trying to bring about those kinds of changes that didn't necessarily need big physical infrastructure? Could they still come to you, and what kind of advice or orientations do you think you would give them?
I think my clear advice is to seek out the conversation as early as possible. I think we would like to be involved in the process again from the beginning. There is the possibility of looking into technical assistance or advisory in setting up projects and to see what type of financing is available. We have supported everything from also public-private partnerships, which I think in health also play an important role, to do a sovereign lending either to hospitals or governments directly. So we do engage as well in discussions with the Ministry of Health directly, or any other entities that look, for example, we supported a project where it was a private sector setting up diagnostic tools, where in essence they were offering a service to the hospital sector, and it was a fee-per-service model. But like this, the public had access to state-of-the-art diagnostic infrastructure working around the clock. So it was a win-win both for the public that could basically get the budgets, instead of having to pay for these CapEx investments immediately, they could go and spread it over several years by paying for the actual use of it. And on the other hand, the private sector had the guarantee of the uptake by these agreements with the public sector. And these are also a type of business models that we see more and more coming. And I think we are also happy to share ideas what we see in other countries. I think this is something that's probably underestimated, as we do not only work in Europe but also outside Europe. We see quite a lot. We see quite a lot of what is happening in the health area, what are potentially innovative models of healthcare delivery, and try to make links. Not everything works everywhere, but maybe we can also support in fostering exchange of ideas or best practices in order to ensure that the project is planned properly.
Thank you very much. That's very helpful. So in a moment, I'm going to turn to my colleague, Dimitra. Please don't leave us, Felicitas, because I would like to invite, we're going to see what has been said in the chat. And then I would like to invite you and Dieter and Clemens to respond to that as we come into a more panel discussion. So let me first turn to my colleague Dimitra Pantelli from the Observatory. Dimi, you are also unable, like me, you are unable to join everyone in Ljubljana, for which we are both very regretful, I think. But you're still able to follow the chat from Brussels. And so what kind of considerations should we invite our panelists to consider?
Indeed, Nick, thank you. Good afternoon, everybody, from Brussels, rainy Brussels. We have had a little bit of a siesta effect in the chat, so it's been quiet for the past hour, but we have had quite a bit of input throughout the day that links very well to what we've been talking about. So I'll bring two main points that you might want to discuss with our speakers. One is the importance of investing when there is unmet need. So how do we ensure we steer investment where it is most needed? And one of our colleagues in the chat made the point that the COVID-19 pandemic has even created new areas, not only, for example, when it comes to mental health, linked to the example that Bila brought us, but also because of disruption of regular service provision, and catching up with waiting times will be quite an issue in the following months and potentially years. So this will require smart investment and swift action. So the point here is, how do we make sure that we invest where we need it the most? This is one. The other one is this importance of trust from stakeholders in the system to enable change. And we heard that from Clemens and from Dita. We also heard it in the chat and in the previous panel when it comes to digital transformation. So how do we handle this relationship between mobilizing financing for health systems on the one hand and the process of change within the health system on the other? Is it a question of which comes first? What can the experience of our speakers contribute to this question? And then finally, the chat reminded us earlier in the day about the importance of ensuring that we don't waste investment and the importance of evaluating new solutions to make that happen. So maybe we heard a little bit about this already, but maybe we can go a little bit more in depth about what the lessons are that we can learn on this from the examples presented today. Thank you.
Thank you very much, Dimi, much appreciated. So we have 10 minutes of the session left, and so let's. I think if I try and ask everybody to answer every question, we might run out of time. So colleagues, you know the 3 questions that we're going to talk about, and then I'm going to leave you each to pick the elements on this that you think are the most interesting. I think that's the most sensible way to do it within our limiting time. So the first question is, how do we respond to questions of unmet need in the particular context of this specific set of pressures that COVID has created? The second, I think, is about how we balance the process of change within the health system, getting agreement. Dita, you talked about, you said it's all about people, talk. But there's also how do we balance that with being able to define a clear program for the financing, the instruments from outside the country? And then on the third point, this question of evaluation. We're used to evaluating our whole pattern of evaluation with things like medicines is we evaluate things before we do them, but then maybe not so much once they're being done. How do we maintain this process of evaluation so that we generate some kind of continuous process of learning and improvement? Those are the 3 areas. If I go in the order of the speakers, so Clemens, if I might come to you first to pick up on, if you're feeling very ambitious, all 3, but do feel free to just pick the 1 or 2 that you most want to focus on.
Pick to 3, Nick, you know me, because my topic is primary health care, and the good relationship the Ministry of Health in Vienna with the European Investment Bank grew out of the situation that we had a very clear plan, that we did know as a government what we wanted to achieve, and we had a legal framework already, and that made it initially very easy to communicate, and that was, I think, that was helpful for the EIP colleagues, but it was also helpful on our side, But don't forget, primary health care, as it is set up in most European EU member states, is a private business, is a small business. When we are moving from single doctor offices now to group practices or centers or whatever, but they are still considered, compared with a hospital, a small business. So, there's another layer of complexity. So we were able to cut through the complexity in the relationship between the bank and the ministry, it's the bank and the government. But the complexity when it comes to integrate all the needs, so to say, the business needs, the existential needs of this doctors all of a sudden becoming businessmen is another complexity layer. And there we have also to do a better job. Of course, we have the intermediate banks, because the EIB needs intermediate banks in that particular way. In Austria, we had 2 banks. But, how do they reach out then to the young doctors? We want to invite, take a loan, invest in your business, and then but this is a complexity we shouldn't underestimate, and we are not used to do that in the healthcare sector. So there is also a lesson learned. We have to do a better job there.
Sorry, not just the content of the plan, and you said you had that clear leadership, but understanding that we need to invest both time and effort in the process.
Yes.
that organizational complexity. And Dieter, if I turn to you, I know that was something that you emphasized, but please feel free to pick up on that or the other questions if you feel more relevant.
Okay, I was just thinking about how we addressed needs, and it was quite a challenge. And the first thing was that we focused on one thing that was really visible, that was institutions. But then, when we created the mental health action plan, we wanted to really address all things and to prioritize. So we did like. The good thing was that the process was already started, so people started to think about mental health in the system. Before, they just didn't think about it. And then we did a lot of roundtables in all regions with different stakeholders discussing what in the process, what they are missing, what we didn't address in the reform. And then we did, based on that roundtables, we did a big questionnaire that we sent to all stakeholders, to service users, to ministries, to regional governments, to service providers, to everybody, to fulfill and prioritize. And then we have a National Institute of Mental Health that is like our center of evaluation of research, and they just did these questionnaires, put it together, and somehow did some modeling of priorities, of what was the most wanted things from everybody and such, and based on that we started to write the national action plan. So I think really before you write a strategy you need to check the needs in the system.
Thank you. And Clemens, I'm sorry, but to come back to you, because you talked about that, I think, as part of that whole process. That was where you started with the primary care reform as well, wasn't it? A sort of a process of engagement and mapping the needs of the sector some years ago.
To convince everyone that there is a problem, because the stakeholders didn't see that they have a problem in the beginning, So I used Josep Figueras and his powers of argument that they all of a sudden discovered, yes, we also have a problem when it comes to primary healthcare.
So if I put words in your mouth, colleagues, but feel free to disagree with me, because the title of this session is about mobilizing and financing for innovative transformations, but it sounds as though in both of your cases there was a step before that, which was to get people to understand what the need was for.
Yeah, but Nick, it's about money, and you only can spend money when you know where you want to spend your money, And money makes the world go round, but yes, but the banks, Felicitas, if I would come without a plan, she would say, go home, make a plan, Because she cannot spend money without knowing where she is spending it, it's a bank,
Felicitas, you're nodding. Would you tell Clemens to go home? You would never do that.
Well, we would be maybe slightly more diplomatic in our answer, but clearly, as I was alluding to, as we assess the projects based on financial viability, but also economic viability and sustainability. So we need to make sure that the projects that receive an EIB financing are really provide a value add to society, and therefore they need to be also economically viable. And this you can only judge if you have actually a concrete idea what you are supporting. So I fully agree that we would look into it. We can be supportive in developing this plan. I think that's what I was meaning with advisory, and it's extremely important to make sure that they have a proper developed project. I would like to raise a few points on the unmet needs, which I think have become evident according to the pandemic. Of course, we have seen as well mental health is something that is popping up tremendously. I think people of all age groups, but also in particular the younger generation has massively suffered from the COVID lockdown. But equally important, we see an increase of cancer patients, as a lot of people were too scared to go to the regular checkups. So many cancers have been detected too late, or treatments have been postponed at a later stage. Chemotherapy has been starting later than normal, and this will clearly also has an impact. The same is the fact for cardiovascular diseases, where again a proper medication and adjustment of the patient according to the situation did not take place, and we also still need to receive the data. What amount of death has actually been linked to the fact that this was not treated in a proper way as a result of the COVID crisis, not directly linked to COVID as such. I think two other points that I want to draw your attention to. I think the pandemic has also shown the dependence on distribution channels to function. We have to be aware that 90% of our APIs are actually coming from India and China. And when these distribution channels were all of a sudden not functioning anymore, also as a result of the pandemic, there was not only a shortage of protective equipment, but we had even some anesthesia or some essential vaccines for infants that were in shortage, and again, resulted in delays of proper treatment. And this is something where also there needs to be some thinking, how can this be addressed in Europe? Is there a need for certain stockpiling? Should we build up our own capacities? How can we avoid these things from happening in the future? And again, do we want to make the financing for this being available, bearing in mind a drug produced in Europe will of course more than being produced in India or China? Is that a trade-off that people are willing to do? I think on a positive side, to not just say the dangers, I think the pandemic has also shown that there's a higher acceptance now on areas like telemedicine and e-health. I think the need for a better digitalization, a better communication also amongst country barriers, I think is also clearly something that is seen. It's much better if you pool information together in order to also come up with correlation to certain diseases. Are you more likely to suffer from severe COVID if you have this and these comorbidities? And to detect the right biomarkers is of course easier if you communicate. And the last point I want to make is about AMR, which I think is the next pandemic, and we need to act now.
Felicitas, thank you very much. You've ended this session with a nice bridge to several of the wider discussion topics that we will be addressing in some of the subsequent sessions, including some of the more strategic discussions tomorrow. I'm sure that all the participants concerned have taken note of those contributions in advance. For now, though, we're at the end of this session, so if we were all there, I would be asking people to give a round of applause. But seeing as we are virtual, I am just going to offer my heartfelt thanks to Clemens, to Dieter, to Felicitas, and also to Dimi, and also to the colleagues behind the scenes who are making all of this work, for which we are extremely grateful. We now will take another short break. So this is your chance for 15 minutes to stretch your legs, have a coffee. If you're in Ljubljana, enjoy the beautiful surroundings. And we will reconvene at 4:15, so 16:15 Ljubljana time. Thank you, everyone.
Thank you.
So welcome again, and thanks again to Mr. Nick Fahy, if he's still with us at Oxford, for his wonderful guidance of the previous session. We're going on now with our next session, which is the last session of the first day of the conference. It will be an expert panel which will focus on strategies for member states to work better together. I'm really happy to announce Mr. Bogdan Tušar, the Director General in the Directorate for Health System Development at the Slovenian Ministry of Health, who will be the expert host of the panel.
Dear participants, dear distinguished speakers, I would like to welcome you at the last part of the conference. I very much appreciate the opportunity to moderate this panel with such distinguished speakers and at such an important moment. Today's discussion will focus on collaboration. Can different strategies bring member states to work better and closely together? Strengthening collaboration across European health system and different stakeholders is one of the key objectives of Slovenian presidency. We are all aware that member states have different needs, different backgrounds, but only good cooperation and information sharing between them can create fruitful synergies. Health systems in member states could clearly benefit from centrally organized, well signposted and flexible European support service for health that would encourage collaboration among health systems, stakeholders addressing similar challenges. Sharing experience, ideas, best practices between member states is the essential need for innovation and mutual learning in the future. Today's speakers will provide us with examples of different types of European-founded collaborative initiatives and their achievements. So I would like to welcome now our first guest and our first speaker, Pierre Delceau. Pierre is a Deputy Director General at the European Commission, Directorate General for Health and Food Safety since January 2020. Before that, he held some very important posts in the European Union too. He studied law at the University of Liège and obtained his master law degree in the Northwestern University in Chicago. Today, he will present the role of steering group of health promotion, disease prevention, and management of non-communicable diseases as a forum for better member state collaboration and best practice transfer. Mr. Pierre, please.
Thank you very much, Bogdan, for this presentation. And first of all, thank you very much for inviting us in this beautiful city of Ljubljana. It's strange to have a meeting which is at the same time physical and online, but that's probably the new world in which we are. And certainly I wish you all the best for your presidency, because health is an important topic. I know you will have a lot of things to deliver, and I'm sure you will do it. So, we'll come back to Ljubljana to celebrate all your achievements at the end of your presidency. Now, you asked me, and the topics of this conference is to look at the future, how to improve what we have, how to make, better use of what we have learned in the past. And if we look at the past, of course, the past which is still the present, the most important past is, of course, the COVID crisis. And the COVID crisis in which we still are, unfortunately, because as we see, we are not yet over with the COVID crisis. But if we look at the lessons from the COVID crisis, what have we learned? Then finally, member states reacting in isolation without talking to each other was not the solution. We were able to make progress, to be successful, especially with respect to the vaccination process in Europe, because simply there was really a cooperation between the different member states, because member states were talking to each other, with the Commission being, of course, playing a very important role. And also clearly the vaccine strategy, deciding to purchase all together the vaccines which were needed to protect our population was certainly a very good example of a cooperation between us, which was fruitful for everybody. Because let's be clear, the vaccine strategy is a success. Now we have enough vaccines in Europe to have 70% of the population being vaccinated, adult population being vaccinated today. And of course, this will continue to increase in the future. So one main lesson of the COVID crisis is the fact that cooperation between member states and with the European Commission is key if we want to be successful in the health sector. Now, you asked me to talk about, this steering group on health prevention and disease prevention, health promotion and disease prevention, which is also a very good example of the way member states can and should work together. Why is it a good example? Because first of all, we don't touch about the competence of member states with respect to health. We know that it's clear that health is the responsibility of the member states. We know that, and we don't want to change that. We don't need to change this. But we know also something, that the health issue in the different member states are quite similar. We heard something in the previous session about mental health. Mental health is a very important topic everywhere in Europe, in all member states. Non-communicable diseases are the same everywhere, unfortunately. We will talk about the cancer, we will talk about, heart diseases. We are all confronted, all member states are confronted with the same difficulties and the same problems. So it's important that having a group like the steering group meeting on a regular basis to try to force member states to talk to each other, to exchange best practices, to try to focus exactly on what needs to be done to have a better situation in all member states. And I have the feeling that this group, the steering group, is working well. A lot of key actions have been identified and have been followed up in the different member states. And I believe this is important and needs to continue in the future. Now, I would like to add something which also is important, and that's a new element. As you know, from now on, we have now a financing, EU for Health, which is a very important financial program, which is there to, help financing actions in the health sector in the different member states. And again, we need to make a link between the steering group and the actions which have been identified in the steering group as priority actions, as actions which are fundamental, and the financing which will be available under the EU for Health program. And actually, I know that in this session, we will have a presentation of joint actions, which have already been decided. But clearly, we need also to use the funding and the financial resources coming from the EU for Health also to help the work of the steering group, because we believe this is extremely important. Again, one key lesson of the COVID crisis, diseases do not stop at the border. Diseases travel, diseases are present everywhere. So we really need to reinforce the cooperation between the member states from that point of view, and because it's certainly the way forward. Now, just one last point, because I know I need to be short, so I will be very short. But one last point which I believe is also important, and that was mentioned also in the previous sessions. We need to look at better preparedness for the future. We need to make sure, we know that there will be other pandemics. We know that there will be other diseases which are there. AMR was mentioned as something which is extremely important. So we need to be better prepared for the future. And so in this context also, as you know, the Commission intends to come up with a proposal to create HERA, which will be a new authority to try to work with the member states. And that's why I mentioned it in this context. The idea is to work with the member state all together to try to be better prepared for future pandemics in the future. So thank you very much for your invitation. I wish you all the best for your presidency, but I have full confidence it will be successful. And now I'm waiting for your difficult question.
Thank you, Pierre, for sharing with us your experience. No difficult questions, I can assure. But really, maybe just one or two questions for you. What do you think? The last COVID pandemic has shown many difficulties around Europe. Do you think that the attitude towards better cooperation between member states has been better, is better, or what?
No, let's be honest between us. when the crisis started, the COVID crisis started, it was difficult for everybody because nobody had known such a crisis, with such an amplitude, something which was so big, affecting not only Europe but also all the rest of the world. So it was something which was new for everybody, and so that's clear that at the beginning, simply member states didn't know how to react. And that's true, we had some attitude like border were closed, difficulties to travel, and these kind of things which were extremely complicated and also understandable. But if you look at, with some background, very quickly, there was consensus between the member states. There was a common effort to try to reopen the border, to find a solution to make sure that trucks will continue to bring foods and, necessary equipment to everybody in Europe. There was also, as I said, already a willingness to work all together to purchase vaccines. And so I would say those are examples of the facts, actually, Europe was there, is still there, and was needed also to fight the COVID crisis. So, of course, it's never good to have a crisis, never good. So I would have preferred never to have such a crisis. But I believe that Europe as such, and member states as such, has shown a great resilience because they've been able to say, we are not selfish, we don't have a selfish attitude, we work together, and together we will find a solution. And that's what's happening now. So to come back also to your question more precisely, I would say this will not be forgotten. Because I'm sure member states have understood that you cannot work in isolation. You need to understand what's happening elsewhere. You need to work together. You need to talk together to be able to develop, attitudes which will be beneficiary to everybody. And my last comment will be, health is fundamental everywhere. So we should never forget this.
So this is very important that we know that we are not alone, and when the crisis strikes again, there are countries are willing to help. You mentioned before also the mental health. This was a very important issue during the crisis. How do you think on that matter countries has gained with this field? Because we know it is somehow more or less neglected.
You're right, it's a difficult issue, of course, because clearly, first of all the attention was focused on COVID, which is of course normal to a certain extent. But it's clear that we have seen that, other diseases have not treated like they should be. For instance, a lot of cancer patients did not go to the hospital, did not get the treatment they were supposed to receive. Now, on mental health, you have two aspects, actually. First of all, those who were already affected by mental health issue were simply in the same situation that as a patients. It was difficult for them to continue their treatment and to make sure that they get the treatment they were supposed to get. But there is another phenomenon. It's simply the fact that people, because of the COVID crisis, because of the lockdown, because of the, some people losing their jobs, their families, their friends, and so on. So it was extremely complicated. And so certainly there is a lot of more people who are affected and their mental health is being affected. So that's an important issue for us. We realize that we need to do something as the European Commission. We organized actually a few weeks ago an event, a big online event, where actually dedicated to this issue of mental health, which was a huge success, which in itself is already an indication of the fact that it's a real problem. Because if you have a lot of people attending such a conference, it's because it's a real problem. And so from that point of view, we believe it's important. So we want to continue to work with you, with the member states, to try to see what we can do to try to address this issue. Because let's be clear, those people who have been affected by the COVID crisis and their mental health has been affected will continue to be affected for quite a long time. So we need to find solutions all together and to see what we can do.
Okay, thank you, Pierre, for now. And we are going towards our next speaker in this last panel at the conference today. So I invite Professor Tiit Albrecht. Professor Albrecht is a senior health service and health system researcher at the National Institute of Public Health in Slovenia. He specializes in social medicine and he dedicates his research to the exploration of health services. He is also an associate professor of public health at the Faculty of Medicine. What is very important, since 2006 he has been actively involved in the European Public Health Association with development of cancer policies at the European level. So during the Slovenian presidency of the European Council and later as coordinator of joint actions on cancer policy at the European Union level, including the European Partnership for Action Against Cancer, Cancer Control, and most recently the Innovative Partnership for Action Against Cancer. So, the European Commission presented a Europe's Beating Cancer plan. With new technologies, research and innovation, the cancer plan sets out a new European approach to cancer prevention, treatment and care. To achieve this, a strong member collaboration was needed in the past. So Professor Albrecht will present the successful collaboration on cancer policy in the European Union. So I invite Professor Albrecht to come to the floor, please.
Good afternoon, ladies and gentlemen. Thank you for the kind invitation, and it is my task today to present the successes of the collaboration on cancer policy in the European Union over the past couple of decades. Slovenia took initiative on cancer policy after EU had a successful Europe Against Cancer program running from 1985 until 2003. So Slovenia's first presidency to the Council of the European Union brought cancer back to the top of the policy agenda. We believe that it was an important moment because it was the year, a few years after the largest extension of the European Union accepting new members. The recommendations from that presidency resulted in the establishment of the European Partnership for Action Against Cancer, formally inaugurated in autumn 2009, and then the call to member states to develop national cancer plans or strategies. Have some problems? Okay. EPAC initiated the first joint action on cancer policy with the same name. The first one was followed by two more with slightly different focuses or foci. The work of the three joint actions resulted in a number of useful policy documents that provided also a sound base for the Europe's Beating Cancer Plan. So, the first joint action, as I mentioned, was supporting the European Partnership for Action Against Cancer. I mentioned the websites also because they are all still functional and you can consult them for deliverables, also other deliverables from the ones that I will mention in this presentation. The second one was focusing on quality improvement in comprehensive cancer control, but it was focusing more on care than other aspects. Screening was there as well, but most of the activities were around care. The current joint action is, of course, extending broader. Oops. So here are the four publications that arose from the previous joint actions. The first two, the volume called Boosting Innovation and Cooperation in European Cancer Control, was a compendium of the activities in the first joint action. The next one is the one that I would like to mention, not because I contributed to it, but because it's the European Guide for Quality National Cancer Control Programs. It is considered to be used for guidance in the preparation of national cancer control programs. It was used by several countries, not only in the EU, but also in other countries in Europe. Then we have two volumes with almost identical, seemingly identical front pages. One is called the European Guide on Quality Improvement in Comprehensive Cancer Control, and the other one is from the same joint action, 5 policy papers. So now bringing us to the current joint action, to the one that is going to end at the end of this year. We have a work package which is focusing on implementation and sustainability. It is led by the Belgian Federal Institute of Public Health called Cienzano. It consisted of 3 activities. The first one was a very strenuous activity where the team visited 20 member states plus Norway and Serbia, and collected in face-to-face meetings, some of them were almost like focus groups, experiences to be shared, problems and challenges in cancer control in all these countries. This was done instead of carrying out a classical postal survey or email survey, and was very fruitful, provided an extreme value and richness of outputs. The second phase is still ongoing. It is the development of the so-called one-pager cases. These can be national or EU-wide or multinational. They will present snapshots of different policies that support cancer control. Finally, our end product will be the sustainability report, or also referred to as the roadmap. So, just to present to you what the main topical areas are, some of them are very comparable to the flagships of the Europe's Beating Cancer Plan, which I will present in the next slide. So, prevention and health promotion, genomics and cancer, registries, their data sets and extensions, current issues in cancer care, immunotherapy for cancer and its reimbursement models, and finally, a work package that I hold very important and almost the key one is governance. We have 5 different leading institutions running these projects, work packages, and they really have done an outstanding job. So, from all these results, from all the deliverables, we are hoping that we will produce very substantial evidence and ground for the support for to the implementation of the Europe's Beating Cancer Plan. We are counting on the compulsory repository for all EBCP project results. This is our proposal. We have a supporting tool for the Cancer Inequality Registry and for the mutual learning platform on cancer control implementation. Of course, also one-pagers represent a quick policy presentation instrument. In this table, I'm sorry, it's very, the letters are very small. I present the 6 topical areas from the current joint action and their matching counterparts in the Europe's Beating Cancer Plan. The health promotion and screening, of course, is a strong focus of the Europe's Beating Cancer Plan. It shows in addressing health determinants, interventions on them, and strengthening of screening with the forthcoming recommendations next year. Genomics and cancer is an important, outstanding topic that will be included in all first 3 pillars of the plan. Cancer registries. We have done something in view of what is coming up with the Europe's Beating Cancer Plan. We have proposed the extension to socio-economic determinants and data on treatments, which will be extremely valuable for the assessment of inequalities in cancer in Europe. Current issues in cancer care is another one that supports the development of cancer care in the future, as well as immunotherapy. Governance addressed all the key areas of cancer care. national cancer control programs, quality standards, patient pathways, comprehensive cancer networks, as well as the so-called PREMs and PROMs, patient-related experience and patient-related outcome measures. We believe that there is a clear synergy between the processes, the process of the development of the joint action and its outputs, and the EBCP. I have to stress that in the joint action we have 21 member states and 2 candidate countries involved actively and participating, and other countries are still contributing in the ways that they can and are able to do so. So in the end, I would just like to thank you for the invitation and for having listened to my presentation, or hvala in Slovene.
Thank you, Professor Albrecht, for your interesting presentation about the evolution of policy of cancer care in European Union. Maybe before we end, just a short question. You have many experiences on that field. So the work on the 3 joint actions resulted in a number of useful policy documents and provided a sound base for the Europe's Beating Cancer plan. How can we learn from the successful joint action you presented to strengthen further member states' collaboration even more?
Yes, I think that the collaboration was running very smoothly. It was supported by a number of institutions. I should mention also 44 additional partners to the key partners from each of the mentioned member states. And we have built a consistent, I would say, consortium, which can be very trusted. And it shows that this two-side collaboration, where you are not working only for the top level, in this case the European Union, but also serving member states with the examples of best and good practices which they can pick up on. I think this was the best proof of our successful work.
Okay, thank you, Professor Albrecht, for now.
Yes, thank you.
And now we are turning to the representative of the Dutch Ministry of Health, Welfare and Sports, who is joining us today remotely from Netherlands. Please welcome Ron Roosendaal, the Director of Information Policy and CEO of the Ministry of Health, Welfare and Sport. He is responsible for information policy in the healthcare sector, the functioning of the Dutch Healthcare Information Council, and quality assurance as to the aspect of information and ICT in the activities of the ministry. The experience of COVID-19 pandemic has shown that e-health solutions have a very important role of the operation of healthcare systems and have considerable development potential. Ron, we are looking forward to hearing you and your conclusions on this topic. Hello and welcome. Hello, Ron. We are back here. Okay. We cannot hear you. Yes, Ron is coming from a long distance, so maybe just a short way. Okay, Ron, we cannot hear you. Maybe we shall just wait for a moment so that these all technical issues will be properly done. No, still no luck to hear from Ron. Maybe we can go to the next speaker, and later on we connect with Ron. Okay? So I would like now to extend a warm welcome to Dr. Anne Fulaondo from Spain. She has obtained a master's degree on biology at the Autonomous University of Madrid and PhD in genetics and molecular biology at the University of Basque Country. Recently, she obtained a master's in research methods and evaluation of health services, health economics, and the National Distance Education University. The joint action on implementation of digitally enabled integrated person-centered care, so-called JD Care, is part of a series of initiatives the European Union has launched to face the challenges of the transformation of health and care of the European Union. We are now very curious to hear your analysis and on how far your expectations have been met. So, and I would like to invite you to take the floor, please.
Good afternoon, everybody. It's a pleasure for me and an honor to be here and to explain to you, to present to you the Joint Action JD Care. So first of all, I want to show you in a slide very briefly the care problems that our healthcare systems are facing today. Of course, we have been talking about this during the conference today, and all of them are very well known. Our care systems are reactive. They are fragmented. We have silos. We have primary care and secondary care, very differentiated and very far away one from the other one, although we are improving. We also have some discontinuity in the care transitions. So when our patients, chronic patients, for example, go from hospital to home, sometimes there is a kind of a lack of coordination right there. And in terms of telehealth services, there is a room for improvement. In telehealth, we also have a weak digitalization. However, we are improving a lot, but there is, again, a great room for improvement. And we also need to have our patients more involved in the decision-making processes. So all these care problems that are common for many countries result in increasing costs. And these care challenges have become more evident with the corona pandemic. So we need imperative solutions. There is an imperative need to find solutions and to start learning among the member states. And here is when our JD Care Joint Action comes into a scene. So our Joint Action it is funded by Kyriakides, and it started last year, and it will last 3 years. As you can see in the full name, we are talking about the implementation of digitally enabled integrated patient-centered care. So this Joint Action is related to action. We will have regions, European regions, implementing good practices. So what we are trying to achieve in this Joint Action, we are trying to contribute to innovative, efficient and sustainable health systems. And to do so, we are trying to provide expertise to assist member states in this way. So our general objectives, first of all, we want to reinforce the capacity of health authorities to successfully address these kind of issues in terms of healthcare reform, especially in digitally enabled integrated person-centered care. And of course, one of the main pillars of our joint action is to support the best practice transfer between what we call early adopters, from early adopters to next adopters. So the consortium of JD Care Joint Action is huge. We are 48 organizations from 17 European countries. And we have 4 original good practices that will be partially adopted and transferred to 23 next adopters. The 4 original good practices, you can see in this slide, were selected by the steering group on health promotion, disease prevention and non-communicable diseases in 2019. And these 4 good practices will be, as I said before, partially deployed, implemented in new contexts. So we have 2 good practices from Spain. we have the Basque Health Strategy in aging and chronicity. We also have the Catalan Open Innovation Health on hub on ICT-supported integrated care. Then we have the Optimedis model from Germany. And finally, we have the digital roadmap towards integrated care from the region of South Denmark. So pieces of these original good practices will be adopted by new adopters. So as you can imagine, these original good practices have their own core features and characteristics, but we can say that there are 4 main components that are in common among the 4 good practices: risk stratification, integrated care, patient empowerment, and regulation. In terms of risk stratification, we are talking about population-based approach, which is not opportunistic and tries to anticipate to the compensation of chronic patients. So we are trying to have an approach which allows us to be proactive. So at the end of the day, with this population-based risk stratification, we pretend to identify those patients, those chronic patients, that have poor health outcomes and can benefit from targeted health programs. When we are talking about integrated care, we are talking about not only structural integration, but also functional. So we are merging functional governing bodies and also the way we are working between primary care and secondary care. Of course, we also need to improve the health and social coordination, the coordination between different care levels. And to do so, one very important thing, one crucial thing is to deploy, to implement integrated care pathways, where all the stakeholders involved in the care provision co-design and co-create the pathways. Of course, we have been talking about this during the conference in different talks. We need co-leadership. That means that we need clinicians, champions that can encourage their peers to be involved in this transformation, healthcare transformation in integrated care, but we also need the support from managerial teams and policymakers. So it's a kind of a mix of bottom-up and top-down approach. When we are talking about patient empowerment, we need patients to be at the center of the care, really. That means that we need them to participate in the co-creation of health programs. We need them to be empowered to participate actively in the shared decision-making processes. And at the end of the day, one of our goals is to implement what is called the value-based healthcare. So we can gather the perception of patients and the caregivers and optimize or improve care processes in target populations. And in terms of regulation, we all know that regulation, changes in the regulation, is a facilitator for transformation. Of course, policymakers' support is fundamental. And finally, we need to have bundled payments. What it means that we are not going to pay by activities or the activity done. We are going to pay in an outcome-based manner. So, as I said before, we have 4 original good practices in joint action Jade Care, and all of them have their own characteristics. But and at the end of the joint action, we will have different next adopters that have selected and deployed pieces of these original good practices. It's not realistic to think that in the joint action, in a 3-year project or initiative, next adopters can implement the whole original good practice. The 4 original good practices have a long journey, which is time-consuming, resource-consuming, and they spend years and years to try to transform their care system. So in this joint action, what our next adopters pretend is to select the core features that best fit to their needs and deploy in their local context. And why is this? Because there is a huge heterogeneity among next adopters. They have different prioritized needs. Their expectations are also a little bit different. Of course, the maturity level in terms of integrated care, digitalization, differs quite a lot. So their ambition for joint action also is different. So based on this heterogeneity, we have designed this mix and match, what we call mix and match strategy. One of the things that we also have developed in the joint action and is already is a three-phase implementation strategy. So the first one, the pre-implementation phase, which is already done by all next adopters, is the preparation for the implementation, where next adopters need to analyze their context, their needs, and at the end of this phase, they define their local good practice, composed by different pieces of the original good practices they have selected. And they also develop the action plan, the operational plan to really roll out the intervention or the local good practice in the second phase. And of course, the third phase is very much related to the evaluation. Here we are going to analyze in depth the implementation process. So we are going to gather learning, and this learning will be shared among all next adopters and the other organizations involved in the joint action. And to do so, we have 3 years. As I said before, the first pre-implementation phase is already finished. So just to finish very briefly, what we expect to achieve in this joint action is to improve collaboration and trust among the participating regions, of course support knowledge exchange and learning, generate evidence in terms of integrated care implementation, and of course ensure the sustainability of the policies at a local, regional or national level. So we want next adopters to implement, to deploy in routine practice, let's say, their local good practices, but in a sustainable way. We don't want these local good practices to end up with the joint action. We want them to have a long way in the care system transformation. So we contribute to the creation of innovative, efficient and sustainable integrated healthcare systems. We want to help achieving the digital transformation in the adopting regions. And of course, we are trying to encourage innovation and, as I said before, enhance sustainability of the healthcare systems. So this is all from my part. Thank you very much for the opportunity of explaining the joint action.
Thank you, Anne, for sharing your experience and to present us with a very interesting project that you have in Spain. Maybe just one question. How do you think European Union can support the other member states to share or to develop new best practices like one that you mentioned in your presentation, to step forward and to share with the other countries in an on-hands way? Yeah,
one of the things that I think that the steering group and other groups are doing is to identify best practices across European countries. That's the first step. And then these kind of initiatives at our joint action are very, very relevant collaborative spaces where not only good practices are shared and learnings are exchanged, but also we are developing effective methodologies to transfer good practices to new contexts. Because as you can imagine, it's very difficult, it's a very complex process to have one original good practice transferred to a new context. Yes. There is an adaptation process that is very relevant. So the methodologies that are already developed in other initiatives or in this one might be reused and promoted by the EU. So the evidence, the knowledge that we are generating needs to be shared among other initiatives or countries. We need to reuse somehow the knowledge that we are creating, not to start from scratch. And of course, having these initiatives, maybe initiatives with a longer duration and more resources will also be helpful to try to encourage and encourage new next adopters or new adopters implementing new interventions.
But what was the main goal, the main reason you started with that project? It's quite a complex one. What did you like to achieve with that?
I think that one of the things. I think that during the conference, the need, the urgency, the priority to push forward the digital transformation in the care system is a reality. And with that basis, and having these good practices in Europe that really have worked very well, I think that have been the trigger to try to take that knowledge, those pieces of the good practices, transferred to other regions. Okay. That's the main basis.
Yes, but do you think that your ideas will be, can you share with the other countries and
yes,
integrate in their own health system?
Yes, I will say yes, because the next adopters that we have are very heterogeneous, so they can be representative of many other regions in Europe and over Europe. So I guess that the methodology, the way of working that we are using in JCare can be transferable easily, I would say, to other to other countries, and the experience that next adopters, that learning also will be very useful for others in the future.
That's very good to hear from you, and thank you very much for sharing your ideas with us. Finally, I am happy to introduce our next speaker, Dr. Kenneth Grech. Dr. Grech is a consultant in public health in the Ministry of Health in Malta and resident academic at the University of Malta. He is currently a national coordinator of the Public Health COVID response team. He is also the co-chair of the European Expert Group of Health System Performance Assessment, which is also his main area of research interesting. During the COVID-19 pandemic, we have seen the critical role of communities, that communities play in providing essential health and social services. In the last presentation, Dr. Grech will focus to communities and their approach to support recovery and resilience of health systems. Please, Dr. Grech, the floor is yours.
Hello, thank you very much for inviting me to give this presentation. I am the co-chair together with André Ries of the EU Expert Group on Health System Performance Assessment, and I hope today in my presentation to give a demonstration of how a collaborative effort that we've had over these last few years has borne fruit and created a system of wider discussion and actually influencing policy also within Europe and hopefully even beyond Europe. I also hope to give a brief update on our work on resilience, given that this is the topic of this conference today. In terms of origins, just for those perhaps who are not familiar with health system performance assessment, it's, you can see the origins in Europe at least bore from the time of the Tallinn Charter during the financial crisis, so to say. And then this work was further consolidated by OECD and WHO until it was adopted also then by the European Union as one of its key and most important measures for assessment. And in fact, the expert group's inception, you could say its baptism started in, when we were carrying out a peer review of the Belgian healthcare system back in 2014. And in fact, we have been operating since then, and it was born out of a need, an increasing need to measure performance of health systems and provide frameworks for evidence-based policy making, which were very important at the time. That was emerging as a very important topic at the time. The expert group is composed of members of all the EU and EEA member states, together with the European Observatory of Health Systems and Policies, OECD and WHO. DG Sante, through its unit of performance of national health systems, provides the Secretariat. It really anchors all the work that we carry out. We normally meet 4 times a year, and even during COVID, we continue to meet 4 times a year online. And to date, we have met 24 times, and apart from other numerous events and occasions. Over the years, we've produced a number of publications and many reports, and we produced 6 main reports. The first one was in 2015 on the assessment of quality care. That was, again, we usually link these reports to whatever is topical, whatever is relevant for European health systems at the time. In 2016, then went on to develop a report on the assessment of integrated care, and we've heard even today the importance of integrated care between hospitals and primary care. 2017, we produced a report on primary health care. Again, this was in response to the needs of measuring better how primary health care performs within the whole healthcare system. And then we went on to produce 3 other reports. In 2008, we produced a report on looking at efficiency within healthcare systems. That was followed by a report on resilience, which I'll be talking a bit more about. And our latest report, which was produced last year in 2020, was on access equity within our healthcare systems. Coming back to the resilience report, this was produced pre-COVID, so to say. It was almost in anticipation of what we were expecting, obviously without knowing. Resilience as such is not it has been on the EU agenda for many years, of course. However, when we carried out our own research as an expert group and collated all the data that we did on the subject, it showed that there was certainly a gap in determining the exact definition of resilience, and then on identifying the proper measurement and assessment measures for policymakers to be able to gauge whether their healthcare system is resilient or not. So there was certainly a gap in this sense. In fact, before COVID, we found that very few European governments had operationalized resilience, both as a concept but also in practice, and used resilience and measured resilience as a separate measure in its own right. However, then COVID, as we would have expected, has changed all this and sort of catapulted resilience both as a concept and also in practice as a measurement tool to be able to strengthen and sustain healthcare systems both during COVID and hopefully now even after COVID. We learned a lot of lessons, both once we were compiling the report, but then we also adapted the report once COVID came about. And we found that there's a need for policymakers to take timely and appropriate decisions, including inculcating and expanding national HSPA health system performance frameworks within their own measurement systems in order to be able to pick out those resilience elements and those resilience characteristics that then need to be fed back into the system to be able to make the system more resilient. However, we also found that there were significant gaps in scope of most of the countries that we looked at in terms of member states within the European Union, in terms of their assessments, in terms of developing new measures to be able to measure resilience and measure governance and search capacity, especially in a time of crisis. Coming now to our own experience within the expert group, I think this has really served as a living example of collaboration, again, in line with this particular session, and sharing of experiences over the last 7 years. We always kept up with current issues, which are certainly relevant to the European agenda at the time. And then this experience also translated into very concrete measures and also funding opportunities, initially led by SRS and then by DG Reform, as we heard also this afternoon, leading to even more collaboration between member states. And this thankfully led to the expert group sort of presiding indirectly or directly over the development of HSPA frameworks in many countries, many member states, including here in Slovenia, where I had the pleasure and the honor to collaborate with my Slovenian colleagues to develop their own national HSPA model, including my own country in Malta, Portugal. Currently there's Ireland and Croatia and Lithuania that are developing their own HSPA frameworks in line with this support that is being provided by DG Reform. A late development then in this scenario is also the development of the HSPA Community of Practice, which was created earlier on this year, which basically brings together a number of experts and exponents of HSPA, where we discuss, we debate, we collaborate in a very informal way. And this is leading now even to the publication of a few reports and to further collaboration within different healthcare systems. So looking to the future and how can HSPA actually contribute towards resilience, really. So I think we very much feel that HSPA can and should be used as a measurement and an assessment tool to be able to assess the investment that is carried out within Europe. Investment both in financial investment and also in terms of capacity investment. We believe it's a very powerful and sophisticated tool to be able to monitor the implementation of different plans. For example, obviously the EU Recovery and Resilience Plan. It would be ideal to link up the various HSPA frameworks of each country to their own resilience plan to be able to monitor the successful implementation of these plans. And certainly it will prove invaluable even post-COVID, after hopefully we exit this crisis, in terms of looking at our non-communicable diseases, our cancers, looking at our primary care, community services, preventive care, looking at search capacity, workforce planning, HR management, and using HSPA as an intelligence tool to be able to gather all the information and data that policymakers need to be able to take the right decisions in a very timely manner. So thank you very much for this opportunity.
Thank you very much, Dr. Greg, for your interesting presentation. So I would just like to ask you, as an expert, as a member and as a co-chair of that European expert group, how do you see the future? You mentioned a little bit, but will you notice that the collaboration between member states shall strengthen? Is this the way?
I think this is the only way, really. I think, and even COVID has shown us this. I mean, the expert group has shown that this collaboration is possible on all levels, both at national level, ministry level, but even at an institutional level. And we've seen this also with other expert groups, the e-health network and other similar groups. However, I think COVID has really shown that we need to collaborate, we need to work together. Obviously, as we know, the virus doesn't have borders, so unless countries really work together to be able to deal with the challenges that we are faced, I don't think that it will be possible to have a fruitful outcome in terms of ensuring that we are resilient towards these shocks, so to say. And this is shown in COVID. Initially, as Pierre also mentioned earlier, I think the European Union, and all the member states within the European were sort of under shock when COVID hit us. We took some time to get our house in order, so to say. But then once we did, I think the collaborative effort was fantastic in a way. And you can mention so many examples now. Obviously the Health Security Committee, the e-health network, which has actually created the EU digital vaccine certificate process now across Europe, the digital platform for the passenger locator form, which again allows freedom of movement across Europe. So many initiatives which we are seeing now at a European level, which obviously will benefit directly citizens and residents of member states within Europe.
Okay. So you mentioned there will be an era after COVID, of course. What is going to be the role of the European expert group at that time?
Well, hopefully we will certainly continue to consolidate and strengthen our role, primarily in producing data, evidence and intelligence for policymakers to make the right decisions. Again, this has been of paramount importance. In the past, perhaps we were not that timely in terms of producing the data. Data always lagged behind by a year or two, so to say. But COVID has really shown that we need the data here and now. We need the intelligence here and now, because we need to take decisions now. And even within the expert group, this last year and a half since COVID hit, we've been discussing within the expert group of how to produce this data and this intelligence in a more timely manner, in a more robust manner, and in a more accurate manner as well. So I think that will see us through in the next few years, certainly, to be able to continue our work that we've been carrying out during COVID.
Yes. How can member states benefit from that expert group? Every member state has his own representative there, but
yes, of course.
How can
primarily we have another methodologies that we implement within the expert group. One of them is sharing of experiences and sharing of good practices. Again, many member states actually take up certain good practices from other countries and implement them or inculcate them, obviously adapting them to the local scenario. So that is probably one of the main benefits that we have found within the expert group, group that could benefit all of the member states. The expert group also serves as a sort of anchor, as a port of call for those member states that are either thinking still of developing their own health system performance assessment framework, and even once they start on that road, we actually sort of, there's always a hand-holding process until you gain the experience and and you acquire the expertise even at a local or national level to be able to measure your performance of health systems in a robust and proper way. Yes. So that would primarily be our role. Yes.
Thank you, Dr. Greg.
Thank you very much
for sharing these interesting thoughts with us. So we are closing and going towards the end of our last panel at the conference today. Ron Rosendahl is very sorry cannot be with us today. So I would really like to thank you, all the distinguished speakers who were with us today. Thank you for the good discussion we did have. And of course, I would like to thank all of you who have participated in the conference and in this panel especially. So now I would like to give floor to our host, Igor E. Bergant. Thank you again and goodbye.
Thank you very much, Mr. Tushar. Thank you very much, Mr. Tushar. So once again, Mr. Rosendahl, the Director for the Ministry of Health, Welfare and Sports in the Netherlands, could not be with us later on because he had another meeting, so he's quite busy these days. Before we summarize the first day of our conference, let us summarize the last session through the cartoons by our cartoonists. So we had Mr. Pierre Delso, the Deputy Director General for Health, and his conclusion, well, diseases do not stop at the border. We learned this lesson for sure. Then we have Mr. Tiit Albrecht from the National Institute of Public Health in Slovenia, who stressed that governance was key. Then, of course, we had Ms. Anne Fuliaondo from the Institute for Health Services Research in the Basque Country in Spain. She spoke about the fragmented health systems. And last but not least, Mr. Kenneth Gregg, co-chair of the EU Expert Group on Health Systems Performance Assessment from Malta. COVID catapulted resilience as an important thing to measure. So thank you very much to our cartoonist who brought a lot of color into the first day. She will be with us also tomorrow. So let us brace now for the summary of the first day, and I am really happy to announce again Madam Petrič, the Director General in the Public Health Directorate in the Ministry of Health of Slovenia, and of course Mr. Figueras, Director of the European Observatory on Health Systems and Policies. So the floor is yours for the summary.
Welcome again for this concluding session. Vesna, how are you today? It's been a long day, very rich day. I don't want to fall in the stereotypes in these cases about food for thought and so on, but there has been a lot of food for thought, lots of ideas. How are you feeling about it? Are you happy?
Well, I think that we have got a lot of good practices on the plate, and it has exceeded my expectations totally.
Perfect. Our difficult job now is to try to summarize that and make it interesting and hold you 10 more minutes to see our take of what we got today. We had our teams, the Slovenian team in particular, and our Observatory team trying to put together some of these ideas that they'll go in much more detail than on the proceedings of the conference. But let me attempt, we'll have a double act with Vesna. Let me attempt to summarize some of these points, and then Vesna will tell us whether indeed she's happy what we heard today. First of all, the high level of this conference shows clearly the importance that is attached to this topic, not only by the Presidency, but by the Commission and the Member States. We're very grateful, in particular, to Commissioner Kyriakides for joining us today and underlining the Commission's commitment and work and support and strength in this area. That was followed this morning with Dr. Kluge, further highlighting the important role that the WHO can also play in providing additional support and advice. And we heard many examples as well of how the WHO and the Commission are working together to serve their common member states. Dr. Kluge's talk also reminded us that this challenge of transforming health and care systems is not only one for the EU, but it is indeed a global challenge. Indeed, during COVID-19, it is clear to us all that we cannot solve problems alone. And as long as health systems throughout Europe remain weak, we all are weak. And we all have to pay dire consequences. He pointed out very, very clearly that it's time for a radical, for a disruptive rethinking of how we do things and the importance of ensuring an inclusive transformation of our health systems so no one is left behind. Inclusion is a very important element, also underlining a lot of our conference today and tomorrow. As Observatory, we're not only glad, we're delighted to have the opportunity to work with the Presidency under the leadership of the technical staff of the Ministry, in close collaboration with DG Santé and the technical staff in trying to prepare some of this background document. We heard from Nick Fahy some of the key elements that I will briefly repeat only some of them. We started very clearly, though the primary responsibility for health systems stays within the member states. The EU also has many tools that can support the strengthening of health systems. That's very clear. Many of the EU tools can provide support even though strengthening health systems is not their primary objective. And that's what's very, very interesting. A lot of the support is not necessarily in tools that one initially will relate with health. The available tools address different parts of change processes. We talked about the complexity of change. Making best use of these instruments typically requires combining various EU tools with different objectives across multiple stages of the change process. This is indeed a complex process, and I think we threshed out some of that today and some of the lessons to do that better. So there's a need to combine different tools, and that creates a challenge for member states of being aware of these different tools and their potentials to support health systems and how to align the objectives and processes between health objectives and the requirements of different tools. So this alignment, and it's to commend the Commission by this effort to bring all these tools together, to aligning them together, and in particular, actually, Mario Nava was talking today about his directorate having support to member states to learn how to use, how to combine those tools together. So as health systems across Europe deal with the consequences of the COVID-19 pandemic, there is clearly, and that came very clearly, I don't want to repeat the word clearly, but clearly so, across all sessions today. There is clearly a sense of greater collaboration between individual countries and the EU level to make best use of all these tools. We heard from countries, and this is where this conference wants to be at the country level, wants to be at supporting transformation, at the cutting edge of change. We heard from countries, we heard from Austria, from the reform of primary care in Austria, which brought together many stakeholders and sources of funds in which EU support was key. But as Clement said, it's the serendipity. It almost happened by accident. So how do we get these accidents happening more often with member states using those elements, bringing stakeholders together and using these great tools available there? We heard from the Czech Republic on the reform of mental health, which took many years to develop, reminds us of the complexities of change and the time that change takes and reform takes. So this showed that a lot can be achieved, but also showed how complex and time-consuming it was for these countries to develop their plans, find the right support and make use to it. And there's been a lot of debate about that. The ex-ante and the ex-post and the process is not just in the implementation, it's the continuing evaluation of that, is the enormous amount on the preparation of that. Even in the case of domestic reforms in Finland, Lisa Maria Voipio was reminding us how useful were the instruments as a key support, for example, regarding the digital infrastructure needed towards a European health data space. In addition to countries, we heard successful collaboration between countries. Pierre Delceau gave us important insights on how member states' collaboration can be strengthened. He talked about the SGPP, a forum, very effective forum for member states collaborate and work together. Talked about best practice in transfer and some priority areas determined by the pandemic, such as mental health and cancer. And it's been two themes we heard already. We heard from the OECD, we heard from Tit Albrecht, which is the next point I wanted to raise, the joint action on cancer that built the basis for the European Beating Cancer Plan, following years of Slovenian leadership. Actually, let's remind ourselves that the first Slovenian presidency and the first Slovenian presidency of the new member states was on cancer. And that was the beginning of a number of joint actions initiatives that culminated with, as I said, the Europe Beating Cancer Plan. But also we heard about Jade Care, where countries who have implemented best practice in integrated care help other member states to transfer and adapt these models to their own setting. Clear example of transfer and transformation, which is what we want to talk about today. And we heard from Kenneth Grech just now about HSPA and how HSPA group, which at the beginning was looked with certain reluctance, now is a sustainable, ongoing process in which member states learn from each other, are prepared to be benchmarked from experiences, learn from each other, and gave us very good examples, for instance, in the area of resilience, among others. All these examples also demonstrated how important existing EU tools are for enabling transformation. However, we can also learn from the challenges in implementing them, and part of why we are here today and tomorrow is making them better. So, implementing them, to evolve them, and strengthen support for the future. Clemens Auer was saying, we need a one-stop shop for individual member states to make best use of existing instruments, and we've seen already the commitment of the Commission to help in integrating them, in understanding them, in coordinating them. So that's a new idea there about one-stop shop for member states accessing all these instruments for health. Clearly, there's a lot to learn from each other. We've been saying that again and again. And clearly, we learned that still member states are doing that alone, bilaterally with the Commission, which is useful. And there's a lot of calls today about doing that together, using together these mechanisms between subgroups of countries. One very important message that was raised by Lisa Maria Voipio, but by many others afterwards, we also need to be mindful of ensuring that new solutions bring good results and are not wasteful. Comprehensive evaluation and adaptation is crucial for achieving sustainable results. So indicators on evaluation and follow-up in a typical cycle of learning is fundamental, and more emphasis has to go in there. In summary, I hope it hasn't been too long, Vesna. I'm sorry, that's what your team and my team have put together. I think it's really beautiful. I love it, at least myself. Hope you love it, because you are the client, you are the leader. In summary, the COVID pandemic makes all of this more urgent. We've heard that many times. With unmet needs being made even worse. Reflection from me here, there's not much we have learned from the COVID pandemic. It was there. These problems were there from prior shocks. From prior shocks and reforms and prior problems we faced as a group. And if anything else, the COVID pandemic has given us the last reminder that things can even get worse, and worse even if we don't do something about it. So we cannot afford years to work out the complex details of all of these different mechanisms. No more than ever. I was talking to Maya Matthews over lunch about how quickly the Commission is reacting. They are building this plane as it is flying at the same time, and rightly so. More than ever, we need a way of being able to work quickly, work together, and work on the big problems that we all face. The aim for the Slovenian presidency is to find ways for making that happen. Build quickly that plane while it's flying, because it needs to take off, it needs to fly. Our aim must be health systems that respond to the current crisis and are ready for the next one, as I said. We must be able to keep learning and changing as in the face of constantly changing challenges, again and again, a theme we heard today. No more than ever, we need leadership and political commitment to achieve that. And I like to repeat this sentence 3, 4, 5 times as necessary. I will raise this sentence, we'll raise this point tomorrow to the panel of four ministers. One thing we learned today: political commitment and leadership. And we cannot fail there. We cannot fail. The next time we will not make it. That was my bit. That wasn't quite the conclusions. Vesna, how does that sound?
Well, to me it sounds perfectly fine, and there's not much to add, to be honest. But I'm very thankful you do the job, and, you know, I can have the last word. It's always nice to have the last word. What I think I would like to add is that it really struck me how much potential is in our countries. And actually how much potential is in us working together. This was so obvious from everything that was said today. There are some countries that really use this opportunity of working together, being members of EU, really well, and they actually are reforming, transforming their systems, and they use the resources, the mechanisms very well in the stage of developing some innovative solution, piloting them, and also in the stage of implementing those solutions. But we have heard today a couple of times that, you know, evaluation would also be something where we could work together. And my country was always eager if somebody came from the outside and looked at us and, you know, analyzed what we are doing. And you remember really well, because you were the one institution that came and analyzed our health system. And this was a very good experience, because it involved all our people working in our health system, and we could actually, we were evaluating our system together with the experts from abroad and combine this inside view from the outside view, and this is always really helpful. So I think there is some potential also in the future to do some work together in evaluating what we do. Then the other thing that really impressed me is how many of our presenters were saying focus on people, focus on people's needs, look at the vulnerable and so on. This is, I mean, this is Europe. This is about solidarity. This is what we are all after. And I have to admit, I am really happy. Today we have looked at implementation, investment, collaboration. Tomorrow we will have the minister in the round table, and we will have some other presentations, and I think we will look a little bit ahead, and I'm looking forward to it. And by saying so, I think I have said all.
Thank you. And I think thank you very much indeed to our audience, our participants, and we hope, we count that you'll be with us tomorrow with a very, very exciting program, as I said, including more technical understanding of investment tools, mechanisms, as well as the panel of ministers, and a final keynote speech by Mario Monti, and conclusions of the whole conference by the minister. Thank you very much indeed for being here with us today, and we look forward to see you tomorrow.
Thank you, and goodbye until tomorrow.